Good morning, Naren. Good morning,
Oh,
all.
morning, George. How are you?
Recording in progress.
Just. Can you hear me, George?
Yes, can hear you.
Yes.
No
Thank
echo.
you. George, can I introduce you to Dr. Baburaj?
Good morning.
He's
Good morning.
from Michigan. Dr. Baburaj. Dr. Jallo is neurosurgeon from Naples in Florida. Am I right? Naples, isn't it?
St. Pete, same,
St.
close
Pete,
enough.
sorry. Okay, I'm just setting up a few things.
Okay, I'll be around. I'll be back.
Thanks. Dr. Baburaj, do you want to check that your presentation is all going through okay? Do you want to? Dr. Baburaj, do you want to share your presentation? No?
I beg your pardon?
Do you want to share your presentation to see everything is working okay, or you're happy?
Yeah, my presentation is open.
Or do you want to share it?
Yeah, you want me to share it for you for a brief
Just to check.
time?
Yeah, just to check everything is working okay. It's interesting, George. Every time you come to Zoom, they have done so many different things. It's like working.
We are
Can you see
building.
the presentation?
Yes,
Yeah,
we can.
it's coming through fine. Thanks.
Okay.
That's brilliant. George, do you want to check your presentation?
Sure. I'm going to share it right now.
Thanks.
Um,
That's
can you
great.
see it? Good.
Yep,
Okay, great.
yes, thank you.
Wonderful.
That's great.
And I'm going to go off Zoom until we start. That'd be great.
Sure.
Hello, dear Naren.
Hello, Nicholas. Great
Nice.
to have you. Thank you.
I'm very happy that I am here with you, my friend.
Oh, excellent. Excellent. Thank you, Nicholas. Thank you. I'll be just back in a second. Dr. Limbrick. Hello, Dr. Limbrick. Thank you very much. And
I'm here. Thank you.
morning, Dr. Limbrick.
Good morning.
How are you, sir? You must be at what, 8 o'clock in, oh, is it 8 o'clock?
This timing is great. Thank you.
Oh, brilliant. Thank you very much. Dr. Limbrick, do you want to check the sharing is all going okay? Do you want to?
Sure.
Thanks. Yep, that's brilliant. Excellent. Thanks.
All right. Do you want me to take it down?
Yes, please, for a minute. Thanks. That's great. Hello, Dr. Christian.
Good morning.
Good morning. Thank you for joining us.
No, thank you for having me, but let me try sharing mine as well.
Please, thanks. That's brilliant. That works fine.
Okay, great.
Brilliant. One more minute to go. That's good.
Morning, Naren,
Morning.
or good afternoon.
Oh, morning, Dr. Patkar. Good afternoon. Good afternoon for you as well. Great to have you. Thank you. Hello, Dr. Boop.
Morning.
Morning.
Morning, everyone.
Good morning.
I look forward to your symposium.
Oh, great. Thank you for joining us. Privilege. So, good afternoon from England, and good morning to those who are west of us, and good afternoon to also to those from east of us. We have a great symposium lined up today on pediatric Chiari. This is increasingly one of the larger practices in terms of the number of people referred to us, and creates lots of conundrums regarding how to manage. And we have got a world-class faculty, a very distinguished faculty, to take us through the important points that will, I'm sure, help in our practice. We have the first lecture from Dr. David Limbrick. Let me just Dr. Limbrick is the chairman at the Department of Neurosurgery at Virginia Commonwealth University. He was previously chair of pediatric neurosurgery at Washington University in Missouri. And he is one of the leaders in pediatric Chiari with the seminal works, and also a very useful reference book that he had published. So without further ado, may I please invite Dr. Limbrick to talk to us about the epidemiology and natural history of pediatric Chiari. Thank you, Dr. Limbrick. Dr. Limbrick.
It looks like he's muted.
Let's see. Dr. Limbrick, you are muted, Dr. Limbrick. Just Dr. Limbrick, can you hear us?
He just emailed saying he's having some Zoom issues and he's re-logging in.
Okay, thank you very much. And for the first session of the lectures from Dr. Limbrick and Dr. Babaraj. We have got two eminent faculties to discuss the points raised by Dr. Limbrick and Dr. Babaraj. Is Professor Olivier Klein, who is professor and chairman of pediatric neurosurgery in Nancy, and also the president of the French Pediatric Society of Neurosurgery. And also Dr. Elias Risk, who is professor and chief of pediatric neurosurgery at University of Texas in Austin. And at the end of the symposium, there will be a link for a feedback to give us feedback. And those who complete the feedback, I will send you a app for Mac and Windows for pediatric neurosurgery calculations, as well as a database on pediatric Chiari that will run on any computer. You just have to get the free LibreOffice installed and a web link to a online calculator for Chicago Chiari outcome scale. So let's see, Dr. Limbrick is. We'll give Dr. Limbrick a couple more minutes. Dr. Christian, did you receive that message from Dr. Limbrick earlier?
On email. I think he emailed everyone. Let's see if he.
We will wait for another 3 minutes. If Dr. Limbrick is not able to log on, by then we'll go to Dr. Babaraj and start the meeting. Then we'll go back to Dr. Limbrick. Let's see. One more minute and then Dr. Barbara, if Dr. Limbrick is still having problem, would you be able to start in a minute?
No problem.
Thanks. Oh, Dr. Limbrick is here now. Good. Excellent. Great.
Boy,
Limbrick.
how embarrassing.
Oh, no problem. I have been using Zoom for how many years? I still find it not the most reliable. So thank you very much for coming back.
Yeah, no, I appreciate that. I think my institution did all the updates last night on our system, and I'm sure that's what it was, but nevertheless, embarrassing.
No, not at all.
Well, listen, thank you so much for the invitation to be here. Today, I think my role here is to set the stage for the rest of the talks and discussion. And so really, rather than kind of talking about clinical trials or some of the research, what I'm going to talk about is the epidemiology of Chiari malformation and a little bit about the natural history with and without treatment. As you know, there isn't much out there about the natural history without treatment because we don't really follow these patients quite as well. But nevertheless, I do have some disclosures, some of which are relevant today, actually. Nothing commercial, but I do have research funding for some of the work in Chiari from NIH, from PCORI, and from some of the key Chiari foundations. As you all know, most of this sort of seminal work was done over 100 years ago. And what's surprising, I think, to us is that a lot of the definitions that Dr. Hans Chiari originally kind of proffered are still in play. And today, really, the main thing we're going to talk about is Chiari type 1 malformation. I'm going to kind of give a little bit of review, which will be very basic for all of you, about other types of Chiari malformations. But of course, Chiari type 1 malformation we think about as caudal displacement of the tonsils into the cervical canal. And boy, my computer's still a little glitchy, I guess. And as opposed to Chiari 2 malformation, which is, of course, occurs in the setting of myelomeningocele. Certainly, we use some of the same treatments from time to time for Chiari 2 malformation, but very different pathophysiology. And of course, it has some very characteristic radiological findings, which you're all aware of. Large massa intermedia, medullary kinking, really sort of malformation or dysplasia of the tectum, for example. And then Chiari 3 and 4 malformation, Chiari 3 being the most severe form, rare, and it's associated with really either an occipital or combined occipital cervical encephalocele, and in many cases is inconsistent with life. Chiari 4 really just being hypoplasia of the cerebellum. And then I did want to take a second and talk about some of the kind of alternative Chiari designations, and especially because later on when Dr. Brockmeyer speaks, he's going to talk a little bit about complex Chiari, and a lot of those kind of cases that are more complex involve some of this alternative descriptors like Chiari 1.5 malformation. And here, of course, we have tonsillar ectopia in the setting of brainstem herniation. And the thing to keep in mind is these are complex cases, and oftentimes in response to a traditional posterior fossa decompression can be complex or unpredictable. But essentially, this is the obex position being caudal to the foramen magnum in association with tonsillar ectopia. And then, of course, Chiari 0 malformation. This was came out of a small series of patients in 2011. We're all sort of thinking about it now as we see syringomyelia. Oftentimes it can be idiopathic syringomyelia or syringomyelia of other etiologies, can be billed as Chiari 0 malformation. But of course, Chiari 0 really is a very specific kind of definition, which is syringomyelia with CSF flow restriction, but with no tonsillar ectopia. And in the right patients, this can be an effective treatment to do posterior fossa decompression. In the wrong patient, the danger here, of course, is that that the diagnosis is not appropriate, and we should not be considering surgery. We won't be talking too much about this today, but it's important to recognize that these are diagnostic dilemmas. And then more recently, this notion of Chiari 0.5 malformation. And this was out of the Cornell group. And what they described is ventral or ventrolateral ectopia or positioning of the cerebellar tonsils that cause compression of the lateral medulla and can give cerebellar, but really brainstem and lower cranial nerve troubles. So, and there's some MRIs here to show this sort of ventral lateral positioning here on the right. When we think about Chiari malformation epidemiology and of course natural history, but primarily epidemiology, what we really need to think about is not the radiological standpoint, but the combination or intersection of radiology and symptoms. This group doesn't need me reminding that the symptoms are oftentimes headaches, visual changes, can be lower cranial nerve problems like dysphagia. We do see syncope, and then, of course, nystagmus and all these things you see on this list here that can come up, but don't come up uniformly, and that's what makes it tricky. And we always think about Jerry Oakes and others talking about the classic Chiari headache. And this is something that I think I and many use in our practice to help kind of distinguish symptomatic Chiari from Chiari in the presence of other kind of headache types, tension, sinus, migraine, etc. So that classic Chiari headache really is the occipital or suboccipital headache. It is elicited by some sort of Valsalva, laughing, coughing, sneezing, and that it's fleeting. And fleeting, so what does fleeting mean? Actually, the International Headache Society helped us with this recently. I think it was 2 years ago. They came up with definitions of Chiari type headaches, and they defined a Chiari headache as being less than 5 minutes. And that's very helpful. As you all know, in your practices, people will come in and they'll have headaches for an hour or 2 hours or a day. So to have a designation from an accredited headache society saying that Chiari type headaches tend to be short in duration, indeed less than 5 minutes, is very helpful. It's helpful in counseling patients. So I want to make sure everybody's aware of that. That's a very kind of a recent but important advance in how we think about this disease. And of course, what is radiological or what is the radiological criteria for Chiari? This is not settled, and in fact is probably more controversial than ever. Most of the work that cites this so-called 5 millimeter rule came out of work in the 80s, really at the advent of MR, where they did an ROC analysis looking at the degree of tonsillar ectopia. And you can see it, I have it in the middle here, where if they chose a cut point of, let's just say 3 millimeters of tonsillar ectopia, so 3 millimeters, they diagnosed a sensitivity of 96% and specificity of 99.5%. So really, by all rights, that's a pretty robust measure. Of course, what we ended up sort of generally using as a field is this 5-millimeter rule. And I think the reason for that is that we're trying to find that intersection of symptoms and radiological findings. Nevertheless, the sensitivity of the 5-millimeter rule is 92% sensitive and 100% specific. But this is based on 25 patients, really, really small sample size. And so people, of course, have gone through and looked at tonsillar ectopia and found that even when we have 5 millimeters of tonsillar ectopia, many patients in these groups, and you can see the percentages here across multiple studies, many of these patients are not symptomatic. And you all know this from your practice, that somebody with 5, 7, 8 millimeters of tonsillar ectopia very often is asymptomatic and is just managed conservatively, for example. And of course, there have been many other attempts, many other metrics to improve the discriminatory capability of MRI to discover Chiari malformation in a way that is substantiated and important, and has largely failed. So in this paper, many different 2D metrics were evaluated. In the end, none of them really sort of stood out as being a robust marker of Chiari malformation and symptoms. What about syringomyelia? So estimates somewhere in the range of 5 to 85 per 100,000, classified by the NIH as a rare disease. When we think about it in the setting of Chiari malformation, up to 50% or sometimes even up to 75% of patients with symptomatic Chiari are diagnosed with syringomyelia if you look for it through MR. Even in those patients who are asymptomatic may have syringomyelia, and as you all know, offering or thinking about considering surgery, posterior fossa decompression in the setting of syringomyelia is a controversy and something we may talk about a little bit later. Nevertheless, syringomyelia is associated with neurological deficits, scoliosis in particular, or spinal deformity, and pain. This notion of scoliosis is something I'm happy to talk about a little bit later as well. Syringomyelia, when we have patients come into our practices with a syrinx, the first thing we need to do is try to understand why it's there, of course. If they come in the setting of Chiari malformation, perhaps it's obvious, but it can be more complicated. Is there a complex craniovertebral junction issue like basilar invagination? That would certainly impact your operative plan. But also, if the Chiari is mild or insignificant and someone is considering this diagnosis of Chiari 0, we need to look for inflammation, infection, tumors, and other associated CNS diseases. So a lot in there, but nevertheless, of course, syringomyelia is an important consideration in Chiari malformation. And so we come back to this. Does imaging prevalence equal disease prevalence? Because most of the studies that we're going to talk about here over the next few minutes are imaging based. Does imaging prevalence equal disease prevalence? The one thing, of course, to study epidemiology, it would be the ideal situation to study all the individuals of the population. This is, of course, not feasible. Could you select a sample and extrapolate? I think that could be done. That has not really been done. So what do we do to estimate the epidemiological parameters of prevalence and incidence, focusing on prevalence here? Well, we can look at surgical series, but of course that's quite biased. Most of the data that we have is around retrospectively available images. There are a number of studies that have looked at healthy volunteers. These are weighted towards adults, so are also biased. And then there are national healthcare systems which give robust data in insurance and payer databases, which are, of course, limited as well. So all these have shortcomings. But the best, probably one of the best cited papers in this came out of the University of Michigan about 15 years ago. And this was thousands of patients who underwent brain or cervical spine MR imaging at the University of Michigan. About 3.6% were identified with Chiari malformation. Of that 3.6%, which was 500 plus, 23% had a syrinx, and most of the syringes were in the cervical spine. The location of syrinx relative to in the setting of Chiari is something that has been studied and is not quite as settled as this finding may suggest. Syrinx prevalence was higher in girls, and of those patients with Chiari, about a third of them tended to be symptomatic and went on to get surgery. So this is the article I think is probably most cited. But when we look at all the data, including much of the excellent work looking at national databases, I think the best way to think about it is a range, and these are really broad ranges. So if you look at images alone, so just neuroimaging, the estimates of the prevalence of Chiari is somewhere around 0.24 to 3.6%, with that last paper I just showed you being the highest. And of those, somewhere between 1/3 to 2/3 of those patients are symptomatic. If instead of looking at image-based estimates, you look at symptomatic Chiari, then the numbers are quite a bit lower. And you can see even in the range of 7 to 20 per 100,000, so much, much less. Looking at that same study of syringomyelia from Chiari et al. From the University of Michigan, the prevalence of syringomyelia was somewhere in the range of 0.83%. But again, if you look at symptomatic syringomyelia in this sort of seminal study from Northern Italy, it's much lower in the range of about 5 per 100,000. It's important to recognize, of course, that the prevalence of Chiari is likely to be affected by age and ethnicity and other factors like race and socioeconomic status. The prevalence of syringomyelia related to these factors is less well studied, but certainly is related to age. Today, we're going to hear about treatment-related outcomes from the other speakers, something that I've thought and studied a bit. Today, we're going to hear about treatment-related outcomes. But in the absence of treatment, what does natural history look like? The best data suggests that it's mostly benign. So if, for example, you did not have any symptoms at presentation, the risk of needing to go on to get surgery is actually quite low. And patients will always ask you, of course, listen, I have this Chiari malformation. What are the chances it's going to get better over time by itself? And it's been studied a little bit, mainly through MRIs, and there's about a 50% chance that it'll remain stable over time, at least for the period of time you'll follow them. In some cases, it can improve. The tonsils can so-called reduce or ascend over a period of 10 to 12 years. And in some cases, of course, it can get worse. If you do see increasing tonsillar ectopia, you should at least be considering whether there's another cause at play. And that could be just in a very small child, the development, but in adolescents and young adults, we need to be thinking about a secondary pathology. And again, in a study of about 200 plus patients, only 4 developed new symptoms, and 1 developed a syrinx. And there is a variability of data here. So About 3% of patients end up in these latter two studies towards the bottom of the slide here, going on to need surgery if initially offered conservative management. It is, of course, important to recognize that there are a lot of modifying factors, especially in pediatric neurosurgery. Many of the Chiaris we encounter are associated with other neurological conditions. This list is exhaustive, so we won't go through it, but many of these, NF1, other phacomatoses, connective tissue disorders, and then, of course, craniosynostosis and hydrocephalus and other things. So this list. I won't go through it, but it's important to recognize how we think about natural history and treatment is very much related to these comorbidities, especially in certain circumstances. And, of course, all Chiaris are not the same, right? This is something that I think that we could be faulted of thinking for many years, although not recently, that that maybe we should be thinking and treating Chiari in a similar fashion. But of course, this example is a 10-year-old male, daily episodes of sharp, fleeting occipital headaches, went on to have a posterior fossa decompression with duroplasty and did well. This one is just a different kind of case. This is a younger child, occipital headaches, was diagnosed with a family and personal history of hypermobility. So this patient was managed conservatively, but you can see, these modifying factors matter. This is a 14-year-old with spinal deformity in what turns out to be quite a large syrinx. And of course, this was managed with posterior fossa decompression with duroplasty. And actually, in this particular patient, the spinal deformity corrected, which of course is an area which we can talk about later. And lastly, this is a patient with syndrome, a syndromic patient with Pfeiffer syndrome, lots of complexity around craniosynostosis, hydrocephalus, ventral brainstem dysfunction, and ended up getting a posterior fossa decompression, but also occipital cervical fusion and ventral decompression. So, there are all sorts of modifying factors. And these are the ones that can be seen, especially in older adolescents and young adults, but CSF leak, venous hypertension, that obviously could be seen from in the youngest of children from the stenosis of the jugular foramen. So lots of modifying factors that should be considered in how we think about the natural history. I'm just going to make a plug in my last minute here that we need to be doing a better job thinking about outcomes. For the most part, many of our studies rely heavily on a Gestalt physician-based outcome. I'm glad to see that we're integrating more standard techniques like the Chicago Chiari outcome score into our studies. I also would like to advocate for patient-reported outcomes in our studies, not just physician-assigned outcomes like the CCOS. Here's one example. This was developed by Dr. Shannon when she was at Vanderbilt, but this is a health-related quality of life instrument, which involves 45 questions across the domains of pain frequency, pain severity, and non-pain symptoms, and then psychosocial influences. So I'll stop there and just say thank you for the invitation to participate today. It's been really great, and I do want to apologize for the technical issues. I have to say, it sounds like an excuse. I've not had that happen before, especially not on the international stage. So I'm somewhat humiliated, but thank you.
Thank you very much, Dr. Limbrick, for that excellent lecture on the complexities of Chiari and complexities of understanding the epidemiology and the natural history, and also giving us a summary of the what we know about the epidemiology and natural history. Can I please bring Professor Klein, Olivia Klein, and Dr. Elias to ask you their comments on your lecture and their questions before we go to the other faculty and to the participants. Professor Klein, thank you, sir.
Yes, thank you very much, and thank you very much, Naren, for your kind invitation and for organizing this session. I first of all want to thank Dr. Limerick for this lecture. It's a very comprehensive lecture, and I only have a few questions or comments. Chiari type 1 malformation is a rare malformation or supposed to be a rare malformation. Here in Nancy, I'm responsible of one of the 6 French center of reference for Chiari malformation, and I see 4 to 5 new cases a week, and so did my colleagues. So it's supposed to be a rare malformations, but most of the time now it's an incidental finding. My question is, do you perform polysomnography when you investigate a Chiari 1 malformation? Because we have, when we find more than 6 sleep apnea of central origin, we proceed to surgery, whether the child is symptomatic or not. What is your opinion about that?
Great question. And I would say that if you can obtain that on every patient, I think it's very helpful. I have to tell you that in my practice, I ask about it, about sleep disordered breathing. And if there's any suspicion, I will follow up with a sleep study. I'm not sure it's feasible for me to get it on every single patient. And as you know, there is good evidence that sleep disordered breathing does respond to surgery. And so I do think there's a great rationale to do it. I think that one thing that I didn't mention, just in the interest of time, is some of the work that our group and other groups are doing suggests that that Chiari malformation is a brain-wide disease, not just a cerebellar tonsil, at least in some groups. So we see all sorts of symptoms that may or may not be related to the cerebellar tonsils. And the reason that's relevant is it may or may not respond to posterior fossa decompression. Nevertheless, I think sleep disordered breathing is one of those that does. So I think it's a great idea, and would love to see more from you and about this. It's certainly an area of interest, and people have written about it. So thank you.
Thank you. Thank you very much. I have a second comment. Just you mentioned it. We have to check for craniocervical junction abnormalities, and if present, we must sometimes do a fixation at the same time of the decompression.
Thank you for that question. I'll just give you a little insight into my practice. Not that you asked, but but I'm going to do it anyway. I do think that I think assessing for that in every patient in some way makes sense, whether it's doing flexion and extension X-rays or looking on the MRI scan for seating of the OC joints, C1, C2 joints. I think it's really important and probably an under-recognized problem. So I really appreciate your comment. One of the things that I have done in the past is help to coordinate the Park-Reeves consortium, and what we did study the instance of requiring our patients who underwent OC fusion in our data set, and it was somewhere around 2.5% of those patients ended up needing it. A little bit lower than I know some people will anticipate. So I would say that my general practice is to start with a posterior fossa decompression, and if it requires OC fusion or some stabilization down the road, then I'll consider that. But generally, it's not my first go-to just because of that Park-Reeves data. I hope that's helpful.
Okay, thank you very much. Just a last word, if I can, Naren.
Sure, of course.
In one of your slides, it is written that it's a disease. So do you think it's really a disease or just a malformation in numerous cases?
Yeah, I guess I don't really know the answer to that. I referenced this, but one of the things we've been doing is testing genetics on about almost 2,000 patients now. And I would say it is that's a tough question. It's a malformation in many cases, but in other cases, I think it is the result of other pathology. And I know that many of you on this Zoom are aware of that and understand, as you've said, the notion of craniocervical instability as being etiologic, or the other things that come to mind are cerebrospinal fluid hydrodynamics, connective tissues, venous sinus outflow. I mean, there are many different etiologies. I think one that I think is that I think about is brain overgrowth. You might say, what is that? Well, brain overgrowth, a good example of that might be NF1, where there's an increased head circumference, and the actual tissue inside the skull has outgrown the skull. So in that case, it may be more of a malformation or mismatch. So I guess that's a long-winded way of saying I think it depends.
Right. So thank
Yeah.
you very much again.
Thank you.
Thank you.
Thank you, Professor Klein. Dr. Elias, can I please invite you to comment and
Thank you,
question?
Naren, for this wonderful symposium, and thank you, Dr. Limerick and Klein. Those were wonderful comments and a nice overview. One question I had was related to collagen diseases. We're seeing a surge of Chiari-related concerns with patients with EDS. Not sure what your experience is in that arena and how to address that. The other comment I had from the sleep apnea, Brandon Rock in Alabama recently put out a nice paper in JNS Beats showing, as everybody's here is starting to notice, that those cranial nerve dysfunctions and sleep apneas are quite prevalent in that patient population. But you also have to compare it to the other Chiari malformation that has a similar pathology, Chiari type 2, and those sleep apneas are present in that population, and we don't do the decompressions on that patient population on a regular basis due to mortality and morbidity. So I'm not sure what your thoughts are in regards to that question. Should it be a factor in our decision making with sleep apnea, or is it more in their cohort they had more obese patients that had those dysfunctions, or more severe Chiari malformations that needed the decompression? So interested in your thoughts on these two topics.
Yeah, thank you. I really appreciate those two comments. The sleep disorder breathing, I'll start with that just by saying it's complicated. I don't think, oftentimes we don't do surgery on Chiari-2 malformation because we worry that much of the pathology is related to the development of the brainstem, or is sort of not necessarily reversible. And I, even in my time in practice, I've seen the field sort of bias towards the treatment of hydrocephalus and supratentorial things rather than decompression. That has changed. Interestingly, I feel like in my new job here, I see more transitional patients, and I see lots of problems associated with prior decompression, which are really challenging to treat. I would say that sleep disorder breathing, at least my understanding of the data is that decompression can help. I think that more to come on that. And Other things we're seeing, dysarthria, dysphagia, and then even speech, like childhood apraxia of speech may be related to Chiari malformation. It's unclear if decompression will help in those things. So I think more to come. The craniovertebral instability, I see that Professor Goel is here as well. Is I think an area where we really need to focus. In my mind, the two things that we're not good at studying right now, whether it's in big groups or small groups, really two of them: pain, the connection to pain, and the connection to connective tissue disorder. So this has got to be a focus of what we do going forward. I would say that I look for connective tissue disorders in every patient now. I do the Beighton scoring myself in every single patient. It's tough to get these patients to get evaluated in genetics or rheumatology or these other specialties where you might want to rely on their diagnosis. So I do it in every patient, and I do FlexX in most patients. And then the last thing, and I will tell you, this is the influence of Professor Goel on my own practice. I look at the OC and especially C1, C2 joints on every single patient. I scroll parasagially to look for that before I'll talk about doing any surgery. I'm sure he'll have a comment about that. My own practice is to rely more on posterior fossa decompression rather than fusion procedures, but I'm certainly open to that and try to do my best to investigate that in most patients.
Thank you.
That's great. Thank you, Dr. Limbrick. Dr. Limbrick, there are a couple of interesting questions on the chat box. If you have time, I would be grateful if you could reply. For the reasons of time, I need to now move to Dr. Babaraj. Thank you very much, excellent, for the excellent lecture and for the fielding the great questions and leaving us with things to think about. Thank you.
Thank you.
Thank you very much. Dr. Jayapali Babaraj, it's an honor to have Dr. Babaraj with us. He's a neuroradiologist at the University of Michigan with a strong interest in neuroradiology. My philosophy is that neurosurgeons might be the commandos, but neuroradiologists are the intelligence officers who tell us where to go. So having a really good insight and understanding of the radiology is paramount for neurosurgery, and it's really great to have Dr. Babaraj to give us a lecture on the radiology of Chiari. Thank you, Dr. Babaraj.
Thank you for that kind introduction, and I'll start off by just giving a brief remark. Thank you, Dr. Limbrick. It was an excellent talk, and it made my life a little easier. Just a minute, please. Can anyone see my screen?
Yes, we can. Thank you.
Yeah. So we've been following up, and we are a bunch of radiologists and surgeons who have got a abiding interest in Chiari malformation. So this is a review of sorts, and I will cover up some issues which have already been shown by Dr. Limbrick. So I have no disclosures, but I'm thankful to a lot of people who made this journey into Chiari very fruitful, especially the patients and the families. And Dr. Cormac Marr, who was my good friend, who is my good friend, and he and I were together for nearly a decade for making all the new discoveries, if I may say so. And then I have my own colleagues in my department of radiology, and also a group of researchers who were in the University of Akron, but now who are dispersed off all over the country. That includes Dr. Frank Loth and Dr. Phil Allen, and of course, all the residents and fellows and postdoctoral fellows who are involved in Chiari research. So my main objective actually is to send us through a journey of what is acceptable in radiology, what is practical to a busy clinic schedule, and what is probable and can make a difference to the patients. And my adage is that we treat the patients and not the images. So I think we can give you a lot of information as new radiologists, but the ultimate dialogue, whether to operate or not, is between the patient and the neurosurgeons, because the patient is in front of you, and then you can hear the patient, talk to the patient, speak to the patient, assess the patient, and see for any other neurological changes. So I will sort of steer away from any controversy, generally speaking. Like, I don't want to be shopping in Bond Street. I'd rather be in Hackney. That's a tip to Dr. Ganesh here. So cerebellar tonsil descent more than 5 millimeter bit of foramen magnum is considered to be the de rigueur for diagnosis. And of course, there are clinical features like headaches, which are very peculiar. We have neck pain associated with the headache. The patients can have tussive headaches. There are issues with syringomyelia in patients, and they develop with very specific symptoms, which are easy to diagnose. And the importance of imaging is that we have to diagnose the lesion itself at the craniocervical junction, and also look for any change in the spinal cord. And as of now, MRI is the gold standard, and CT is used for mostly looking at bony abnormalities. So this was one of the earliest papers which we published about the robustness of the 5 millimeter tonsillar descent criteria. And this paper actually showed that there are 3 different types of tonsillar morphologies which we look for. And everyone should agree that the most important one is this abnormal pointed looking flattened cerebellar tonsils. And then there is this intermediate tonsils, which is kind of truncated, but does have a leaf-like morphology. And then the other tonsils is mostly like a rounded tonsils, and which we generally term as low-lying cerebellar tonsils. So distribution of tonsillar positions was important for us. And when we started off, and we classified these into these 3 different morphologies, and it was very important. And even now, it's one of the guiding principles to call it as Chiari 1 malformation per se, and just leave the others as possibly calling them as low-lying tonsils, and then let the surgeon know about this particular entity. And the surgeon will then actually go back and assess the patient and see whether or not that is actually causing any symptoms or not. Because there is another aspect of this, because as a child grows, the tonsils ascend, and that has also been proved by a large series of patients, which we already looked into. So whatever said and done, the correlation between the tonsillar descent has to be correlated with the symptoms, and see for any changes in the CSF flow and presence of a syrinx or a pre-syrinx. The pre-syrinx is a term which is used for non-specific flare hyperintense or stir hyperintense signals in the cord, which is seen usually in the cervicothoracic junction. There are a group of patients in our cohort of studies which showed that there was about 3 to 5 millimeter descent of the cerebellar tonsils below the plane of the foramen magnum, and they were asymptomatic. So we just let them be, because it was just an incident finding. More about it a little later. So what about children who have this asymptomatic cases with tonsillar descent? We found that too. There's this large ABCD cohort of patients, that's the registry for adults in brain cognitive development studies. And practically every major research institution has contributions to this database of MR for the brain. And we use this data to look for any changes in tonsillar descent or any changes in the tonsillar abnormality. And we did find that there were about 106 subjects which had this sort of a tonsillar abnormality, but none of them actually stuck. Actually, that the tonsillar abnormality was just a rounded tonsils, which was incidental. So we came to know that in these cohorts of asymptomatic children who are not being scanned for any symptomatic symptomatic Chiari, we do find, it's kind of a prevalent data that is there. And this was a paper which was very gratifying for us to know that, yes, not all tonsils are Chiari and not all Chiaris, are unique to that particular symptom, in the sense that we have that headache and the presence of syrinx. So what are the limitations of this 5 millimeter criteria? It's not a standalone criteria, and in my opinion, clinical correlation is essential. So, and there's a lot of variability, because people have said that the variation in the tonsillar descent ranges from 5 millimeters to 27 millimeters. So there is always a risk that you are calling it a Chiari malformation, but they have to be, labeled as mild cases or are asymptomatic. So the best way to resolve this issue is called that the tonsillar abnormalities there. The tonsils are flattened, they are peg-shaped, they do not have a rounded configuration. Once these 3 criteria are met, at least in my practice, I will not label them as frank Chiari 1 malformation and simply say that they are low-lying cerebellar tonsils. Then there is an issue which was raised in some institutions about whether to have a standing or upright MRI to see the tonsillar descent. Because if there was a tonsillar descent and it was gravity which was aiding the tonsillar descent, maybe that was considered to be abnormal. So the correlation of Chiari 1 malformation and gravitational forces can be extrapolated only. It is not de rigueur that the tonsils can fall down. And for this, you need an erect MRI. And I don't think many centers do have that particular luxury of having erect MRI, where you can make the patient sit down and then see for the tonsillar descent, and then actually do another study in the supine position to see and assess for tonsillar descent. So it is there. It is one of the most esoteric sort of investigations one can do for learning about Chiari 1 malformation. But again, it is still in the realm of a conjecture of sorts, that there is some role for gravity to aggravate these patients' symptoms. So I just leave it at that. This is going to be a discussion which is actually centered on that vertical MRI availability. Then the other important aspect of Chiari is to look at where is the tonsil descending, because we have 2 tonsils. Everyone should realize that. So it's always better to have a look at the coronal images, because that shows if there's an asymmetric descent of the tonsils. And this is a very frequent finding. I don't know the exact incidence of this, but most of these surgeons, and even myself, will look at the coronal images. We always will provide some coronal image, even if it's after giving the contrast, and even if it's a 3D acquisition in the sagittal plane, and then you just extrapolate it down to a coronal image. That tonsillar asymmetry is important for me, and this has been pointed out by Dr. Sean Tubbs, and hats off to him that he noted that. That was a seminal paper, because I'm just taking that illustration for him, which actually showed that there was only 1 tonsil descended on one sagittal image. It was actually the coronal image showed that there is a descent of both tonsils. And there is a commentary for this particular paper, which was by the redoubtable Charlie Rabo, and everyone knows that he is the guru for pediatric radiology. And then he mentioned in his commentary that as a neuroradiologist, he would rather have a look at the coronal images as well, so as to make the correct diagnosis of a Chiari 1 malformation. And oftentimes, we just scroll through the sagittal images, and if you're not sure of looking at both the tonsils, perhaps we may miss the diagnosis of a Chiari 1 malformation totally. So I think these 2 papers are seminal in the sense that all of us see it, all of us know that the tonsils are bilateral, and very few of us will actually comment upon in our report saying that this tonsillar asymmetry is there and one tonsil descends more than the other. But practice should change, and I think I'll advocate for that because of the incidence of these. And nobody's actually published this data because nobody actually is interested to know it. Because once a diagnosis of a Chiari-1 malformation is made and the patient is symptomatic, obviously the diagnosis is done and the patient goes under surgery or is put on conservative management. So next is, okay, now we've had the tonsils and we know they are descended. What is the cause for this descent? And the cause for the descent has been investigated extensively, but the whole concept of this thing is, when I look at it, it's kind of very funny, because we are looking at the cerebellar tonsillar descent, but all the morphometric analysis have been done for the surrounding structures of the brain. So so this again is a paper which was done by the Introvert group at the University of Akron, and which Dr. Limbrick also showed that, we did this, and the idea was to get the mid-sagittal plane as accurately as possible in all patients. So Conquer Chiari Foundation, had these images of 1,000 Chiari patients, and 99% of those patients were women. They were all adults, and that is the reason why it was very easy for us to go and look for all these landmarks from the posterior cranial fossa, and just make our estimation of these changes which are there. And there are several measurements which we took, and all of them did show that there were some reliable differences in the volumes or the area measurements for the posterior fossa, which were different in Chiari patients compared to normal adult females. So that's how the whole concept of small cranial fossa was sort of propagated, and it's still there. And I don't deny the fact that there is some changes in the posterior fossa, which actually makes the tonsils go and descend below the plane of the foramen magnum. But also there is a volumetric assessment of the cerebellum as well. So that volumetric assessment of cerebellum was done in the next series of estimations, where there was an involvement to see for any rotational abnormality in the cerebellum, where it sort of rotates on itself and the volume descends. So a different sort of a program was used. And then we found that there were 18 parameters which were significantly different between Chiari 1 malformations and normal controls. And that is important because once we started to measure the volumetric assessment of the structures, a lot of things came into play. First of all, it was the brainstem which rotated, and there was this chances in looking at the fluid below the level of the tonsils, going up to the level of the C1 vertebra, and then all those issues started to come up in some degree of clarity. So this was another different type of morphometry that was employed, and there were two different programs which were there. Now, these programs are actually MATLAB based, and they're very simple to design and to incorporate. And it takes about 5 minutes for us to get all the results for the data, provided we have a mid-sagittal images. And that is one thing which is important, because oftentimes when the imaging takes place, that mid-sagittal plane is always kind of missed, because we need to have the entire corpus callosum in one image. So if we are doing a 3D acquisition in a T1 weighted sequence, this is very easy to get, because you can sort of extrapolate it and make a multiplanar reconstruction to get that particular corpus callosum into picture. So so this was the second aspect of morphometry, in which we looked at volumes and we looked at the cerebellum per se, and looked for any changes in rotation of the cerebellum, which actually was present in these, and it was considered to be abnormal. Then we had a look at what is the actual morphometric analysis of the craniocervical junction imaging. So what we did in here was we looked at the measurements of the cervical spine here, and we had a bunch of measurements, including the retrodense area. We looked at the distance between the edge of the clivus and the top of the odontoid, and we looked at the area or the length between the odontoid and the posterior arch of the C1. And we noted that in these normal children, there was this sort of a flow of data where, there is a change in the dimensions of the lesions as the child grows and reaches up to adulthood. So, like we had these, like 3 years old, and then we followed them up with 19 years old blocks. There are 15 candidates in each area, each block. And then we looked at all these and we found that there are changes in the cervical, in the craniocervical junction structures. We were especially looking for changes between the occiput and the lateral mass of the C1 and the atlantoaxial joints in the lateral position. So we made 4 measurements at one at the edge, one at the 2 edges, and 2 right in the middle, with equidistance spaces between the 4 measurements on each side of the neck, of the cervical spine. And we did see that there was this sort of a gradual change that occurred over age. So that makes this a very dynamic change. So what it tells us is, okay, now we have this. So now we are looking at a growing skeleton. And that is the reason why now it is important for us to realize that any manipulation with the growing skeleton, we are not going to predict it when the child is, as he goes into adolescence. So it is like Dr. Limbrick said, it's going to be it's going to be walking like a tightrope if you're trying to do any surgery to the craniocervical junction, in patients of Chiari malformation, because at the back of the mind, one should always be aware that this is a growing skeleton and there are changes which are occurring in the osseous portion of the skeleton in relation to the skull base in normal children. So it is important to note that point and then sort of move forward. That's what we did. We looked at morphometric and volumetric comparisons in 102 children with symptomatic and asymptomatic Chiari malformation. This is a logical sort of a extension of measuring that. And lo and behold, although we did find changes over age, we did not see many changes in the morphometric and volumetric comparisons of children who are symptomatic and asymptomatic with Chiari malformation. So that assures us, that, okay, now we are in firm ground that, these children will grow normally and they will have a normal this thing as far as their osseous growth is going to go. They have a problem with their cerebellum. They have a problem with their cerebellar tonsils. They have the problem with their symptoms, but their bones are okay. They are not going to go anywhere apart from what is expected in the normal growth when it occurs in over a period of time. So there was no changes we actually found. Literally, it was kind of a surprise for us that even 3D volumetric evaluations in that small group of patients were not very cohesive enough to say, okay, this is really abnormal, and I need to go back and grab this particular aspect and just propagate it across the country from coast to coast. So this was an important finding for me as well. And I just said, okay, here comes the big deal, like don't treat the images, treat the patients, like that's important. The patient is symptomatic, the patient has a syringe, the patient has a pre-syringe, patient is not improving with a conservative management, then, like, okay, here's my team. Okay, now I'm presenting this serial evaluation of the patient and see that, this tonsil is not moving, it's just sort of jammed there, and then just evaluate the patient and see what to do next. So as a corollary, like we did this, we also made the same measurements which the Akron group did, and we found the same results here as well. We did not see much difference in children. In adults, we did find changes, but in children, we did not. So there is some sort of a play here that in children, it's much more of a stable sort of a picture. They move very slowly over a period of time, and it's inexplicable as to why these patients have these symptoms. And then we have to go back and look for a new cause for this for this association. So then there was this more recent this thing which was sort of again corroborating our findings. What were the demographic co-founders of volumetric MRI, and then we found this again. The linear measurements of posterior fossa are not strong predictors for posterior fossa volume. So that's another thing which was important for us. Again, harking back to that entire concept of having to measure things which are outside of the cerebellum and tonsils to sort of explain what is happening to the cerebellum and the cerebellar tonsils. So this is an interesting sort of a thing which I find has not been really answered in radiology literature. Then, was there anything to do with the rest of the brain, like of the head totally? So we were looking at some data about Crouzon's disease, and we did find some isolated case reports which said that yes, craniofacial abnormalities or sagittal suture closures, were affecting the overall cerebral intracranial volumes, which was sort of expected to push the cerebellum down more inferiorly and then cause some sort of a Chiari-like picture. But in those instances also, it is not very defined whether the cerebellar tonsils have that abnormal peg-like appearance, which occurs in now what I should call idiopathic Chiari, because this was a cause is there here for the tonsillar descent. So it's kind of a secondary Chiari which is occurring now in some patients. So we did this again, we found out if there's anything in the central skull base which actually causes and it sort of explains that small posterior fossa and may cause that tonsillar descent. And we did find some of the parameters for the sphenoid bone and the sphenoid sinus, which were kind of expected, like in the sense a smaller volume of the sphenoid bone and a larger sphenoid sinus was one of the correlates for this. So this was an extrapolation of what the central skull base should look like for Chiari descent. And so it is important for us to realize that, here is another complex interplay of structures here, and we are not sure as to why this is occurring. Then when we realize, okay, now this is a thing of the soft tissues and bone. So what else is left there? There's vascular structures, and then there is CSF. So the next important aspect of research has been acceptance for CSF flow studies into the diagnosis and management of Chiari-1 malformations. So there are several techniques available now, and it's like a market. So initially we started off with phase contrast, 2D images, then we incorporated 4D, having a time factor to it, and looking at the small CSF motions which occur during a set phase of time instead of the bulk CSF, which is of interest in syringomyelia, for instance. And then there is something called a real-time phase contrast or a flash sequence, which sort of uses a very rapidly changing gradient to see the CSF flow, something like what you do it in perfusion scans. Then there are changes like pencil beam imaging, and then there is a time slip sequence, all of which actually have the same sort of a basis that you sort of insonate, and I shouldn't be using that word, but you insonate that particular slab of tissue with a fixed radio frequency pulse, and repeat the radio frequency pulse over several times and change the entire gradient or the magnitude around that particular area to get a signal. And then you can also do some sort of a pseudo flow sort of a thing, which is called a steady state free precession. In fact, you take a large volume of tissue and then you insonate that and you obtain a T2 weighted sequence and just see over a period of time whether or not that tissue itself is sort of moving or not, because you can take that and run it as a cine mode and then get a wonderful image of pulsation of the cerebellar tonsils. And so there are publications there which say that, okay, the tonsils is jammed, and that's why there may be an issue with the CSF flow, and the patient may be symptomatic for that. Now, even the cine flow also will give you the 2D, which is the the original way of looking at CSF flow can also give you the same information, provided you look for it. The whole problem about CSF flow is that when it is given to in a patch system, so there is a volume result sequence, then there's a magnitude sequence, and then there is a subtracted sequence. Depending upon how many cycles of RR intervals you are looking, they'll be varying between 14 and 16. So you'll have at least 48 images in that one particular sequence, but you have to look for which of the sequences actually showing you the flow, and you run the sequences in a cine mode. You can run the cine mode in a flash within, but you can run the cine mode very slowly and then see the flow of the CSF and the motion of the tonsils together. It's fascinating to do that. And a lot of people spend time to do, looking at it, especially in my cohort of neurosurgeons. You know, they will ask me, you know, when they'll, it's kind of very funny. They said, you know, this is not really worked out. You know, there has to be some issues with the acquisition. I said, yes, you know, there is an issue because it's cardiac gated. And that is the reason why, you know, like supposing if the flow is not, if there is a change in the RR interval, you know, your acquisition is not going to go all that well. So, and then, of course, then the last but not the least is the displacement encoding with stimulated echo. This is one of the best sequences, I think, and people at Duke have done this, and it's an excellent study. It gives you a lot of information, but again, it takes a long time to do this. Time is another important here. So that time constraints can sort of mess up with the CSF flow, and you know, children can be very capricious. They will not cooperate. They will not, and you have to really talk with them. And all this has to be done without any general anesthesia. So this is a newer review which has come, and I think hats off to Dr. Patelia, who is the pioneer. And I think nobody in the world did this, and he was the first one actually to start this in Boston. And then, you know, he and John Oshinsky, you know, are the living gurus for it. And it's a pleasure to read their work. And this is a cohesive summary which is there. And I just took the previous list of techniques that have been used, and all of them have got their own peculiar way of, very nuanced way of looking at CSF flows. So what is the take-home points about CSF flow studies? You know, normal non-obstructed CSF flow and brain motion is an indicator that the posterior fossa decompression will not work. So, and severe restriction of CSF flow indicates surgery will be helpful. So then there is an increased hindbrain motion, which is an indicator for surgical improvement. And that's everyone knows, because that's a very tight looking area between these, between the clivus and the occipital bone. And that's where you're looking at. And that's what you're trying to do. You're trying to do a suboccipital craniotomy, relieve the C1 osseous confines, and let the tonsil breathe. And then, you know, and then, of course, you know, there's this whole big conundrum of duroplasty and with and without duroplasty. I'm not going to go into that details. So the biomechanical environment is what is to be studied here. And it's a physiologic challenge that has to be given to the cerebellar tonsils to do that. So you have to cough for 15 seconds. It's very difficult for children to do that, or do 15 seconds worth of Valsalva maneuvers, or 15 seconds worth of doing a jugular compression. That's next to impossible. You just can't be able to do it. It's very clumsy to go and sit inside the magnet, sit very close to the patient's head, and press on the jugular veins for 15 seconds at a time to get that particular thing without motion. Without motion, we need to get all the CSF flow studies. It is a challenge, and believe me, it's not very easy to do. This is how a phase contrast study should look like. There should be a biphasic flow of the CSF, you know, like it should go up and down, you know, depending upon where you've selected your bank and what is the direction of the flow you're selling. Here in my my practice, the downward flow is always dark and the upward flow is always white. So it will sort of change very gradually. And this is a cine run for the CSF flow at the C1, C2 junction. Once you have the 2D flow, then a lot of things can happen, which are very exciting. And, you know, these are below the is above my level actually, and it's a thing which actually designed by a whole bunch of intrepid researchers in CERN and now in Idaho. And Bryn Martin is my good friend, and he showed me how he does that. So in a given volume of the CSF in the cervical spine, they sort of segmented out areas and then looked at time-resolved CSF flows in each segment, and then they strung together the entire data, and they found that there are changes in those particular segments of this cervical spine, especially helpful when you're looking at very turbulent flow ventral to the cord because of the dorsal obstruction due to the presence of the cerebellar tonsils. So it's fascinating to see it. Whether or not it has got clinical implications is very difficult for me to assess, because nobody actually then can go back and say, okay, I'm going to do a repeat study and see whether or not this is really working or not, especially the 4D studies, because it takes a lot of long time to do it. It's 45 minutes of scan time in a very high precision 3 Tesla environment that you need to get and see the entire segmental flow of each pixel of the CSF in ventral and dorsal to the cord. Some people are also looked at, this is practically done. Looked at the CSF flow in the cerebral aqueduct. But the cerebral aqueduct you never touch. And that is the reason why I thought this was like a thermometer. And we found that there were changes in the amplitude of the CSF flow in the cerebral aqueduct, which was changing before and after decompression. And this is a published data. And this is an example of how the cerebral aqueduct flow looks like before and after ventriculostomy in novel pressure hydrocephalus. You can put an ROI on this and get absolute measurements of the peak flow, the mean flow, and the changes over a period of time. And you can quantify this flow and give a number to this, and that's very important. Now, when we give a number to it, but we don't know what is the normal, because it has to be done under normal standard conditions. So even if you have done that normal standard conditions, it's very difficult for us to extrapolate that in patients, because patients will not be done in the normal, in a research scanner. They will be done on a clinical scanner. You can just simply tell the tech, okay, do this. The patients can come during vacation time, they can come during late hours, and there's no supervision there. But even then, with all those constraints, we were able to show that at least the cerebral aqueductal flow can act as a very sensitive indicator for changes in surgery. And it usually, since we had very good results and all of them improved, we know for sure that that particular result holds true. But what about the patients who do not improve? And we don't have any data for that, because the case selection in our institution was such that it was geared for severely symptomatic patients who underwent posterior fossa decompression and had an excellent postoperative resolution of their symptoms. So this is just an idea as to where to go back and measure that particular CSF flow. So it was decided that we will not measure it at the site of the tonsil descent, but just below the level of the tonsil descent, because that will be exceptionally sensitive to any motion or any turbulence of motion which will be occurring because of the protrusion of the cerebellar tonsil. Because considering that that CSF is a Newtonian fluid, and we can sort of extrapolate that the changes which are there, the pressure measurements which we can extrapolate on a phase contrast MRI will be equivalent to what is there in real life if the patient did not have decompression. And again, the CSF flow patterns and the tonsillar descent were measured by very specific assessment of the brainstem here. Here, we are not using that many parameters for the osseous confines, but we're looking at just the soft tissues and then looking at and corroborating the CSF flow studies and then making any assumptions that one or two of these changes in these particular parameters will change the CSF flow and the patient will improve. So what are we looking for in the CSF flow? I showed you the aqueduct, but most of us will be very familiar with this sort of a flow study where the CSF flow ventral to the cervicomedullary junction is being looked at. In many instances, you will see that there's a retroflexion of the odontoid, which will sort of significantly narrow the CSF spaces ventral to the cord. And that jet, has a very peculiar physiologic parameter to it, in the sense that there'll be so much of turbulence there that when you actually measure it in the axial plane, in the through plane, you will see that there is a substantial abnormality in the flow, and there are a lot of vertices which will develop. And that is a thing which we need to go back and look at. And you can look at it, objectively by putting an ROI in the axial plane, or you can look at it as in the sagittal plane and just subjectively say yes, that CSF pulsations is actually damped or not damped. Here in this particular instance, because of the tonsillar descent, you don't see much pulsations posterior to the cervicomedullary junction, because the tonsil is sitting there and it is not moving. You cannot see any phase shifts in the tonsil, suggesting that this patient is symptomatic because of the tonsillar descent, which is sort of very cramped in that dorsal CSF space, and just limited by the posterior lip of the foramen magnum and the C1 vertebra. So when we are looking at CSF flow, there are many ways of doing it. But what we decided was we're going to look at the CSF flow, just at the C1, C2 junction, but we will exclude the denticulate ligament and then see in anterior and posterior to the ventral and dorsal aspect of the cord. And then we got results which were kind of varying. If you looked at the CSF measurements over a period of time, you could see that there were changes. If you look at segment out the CSF parameters, and they were, if you plotted it, there was definitely some changes which are available, which we looked at, and we were kind of very sad because it really did not reflect us into any sort of direction, because the CSF flow, if you averaged out everything, if you can see in this, the 3D profile of each pixel taken at the C1, C2 junction, you'll notice that even in the tyro can make out that the upward flow and the downward flow nearly cancel out, and there's hardly any changes which we can substantially say that has improved in patients before and after surgery. We also looked at CSF flow with the impact of neck flexion and extension. Now, the problem with this particular concept is that it is limited by the coil which we put on the head of the patient in an MRI. Because, in children, it is easy to do because they have a very small neck, and relative to the coil, the head volume is also small. But in adults, it's very difficult to do. And most of the times, when the patient is extending the neck, the chin will hit against the coil, which we don't really want, because it can cause sort of heat to the chin, and it's very difficult for us to go back and reproduce the same degree of neck flexion and extension. And then what we found out in this particular study, which was not published because it did not gain acceptance at that time. I don't know the reason why. That we did not get any small differences. There were so small differences in the anterior and posterior CSF flow, and there was no impact on the neck motion. The cerebral tonsils did not actually go up and down like a piston that's described in the early literature. So we really didn't see that. It's kind of very disappointing, but we did see something which was important. Although the neck position had no impact on the aqueductal CSF flow, but the aqueductal flow decreased following decompression surgery, and that actually made us to have a standalone report on looking at the aqueductal flow, and then we published that data in JMRI, where we actually showed that yes, there is a change, and that's measurable, and it can be done. It's very easy to do, and it's kind of replicable over a period of time. So what was the summary of this entire neck flexion test? That the CSF flow was smaller in Chiari patients pre and post surgery, and then flexion extension did not have any impact on that. So I think that if you're thinking in terms of some sort of a mobility issue, or trying to fix up the cervical spine or do something in that extent, it is not really going to help the patient, because the CSF is not moving the way one would think about it. So this very subtle way of indicating that what you need to do is to look at the patient, look at the symptoms, look at the strengths, and look at the pointed cerebellar tonsils to make your call about doing surgery or not doing any surgery. The next important thing which Dr. Ganesh Lingam pointed out was for me to study about any intracranial hypotension and tonsillar descent. Now, intracranial hypotension will occur when there is a spontaneous or an acquired CSF leaks somewhere down in the CSF pathways. It could be in the dura, it could be anywhere in the dura, it could be because of a spur, an osteopathic spur, it could be because of a venous fistula, it could be some sort of a post-traumatic tear, it could be post-LP. So these are very, very typical presentations with the patients will have postural headache, and then there'll be a typical headache, which is frontotemporal. And then there is this sagging of the brain, which resembles a Chiari malformation, but it's got several other issues with it. First of all, there's because of the low pressure, there is this reactive edema, or some people say that it's inflammation or some low-grade inflammation, but I don't know, because nobody has done a pathology on that. The pachymen just become very thickened, and they start to enhance. And because of this changes in the CSF flow, and that and depending upon how much of the CSF is leaking, there will be this engorgement of the major dual venous sinuses. And what typically happens is, together with the cerebellar drooping and the tonsils coming low into the spinal canal, the corpus callosum also will have a drooping sort of a splenium. And that is so typical. I mean, even a tyro can diagnose that this is this is spontaneous intracranial hypotension. So, but then there are quantitative assessments for measuring intracranial hypotension. There are measurements which you can do, which are well documented, and these are validated measurements. So if you measure them and see the mammaloponic distance is less than 6.5 millimeters, or you can look at the interpedunculair angle, all of them can give you good results. But nevertheless, none of these are actually seen in a Chiari malformation. So I was kind of very wonderstruck as to where this sort of a conundrum comes in, and why is this important that the patients have got this hypotension and they're calling it as Chiari. Because first of all, it has to be a great effort to look for where the CSF leak is, and that is a different village by itself. And we do that. You can do X number of maneuvers for getting that CSF look, and we demonstrated in those patients who have this typical presentation for spontaneous intracranial hypotension. Here's a typical example how it looks like, in the sense that there's thickening of the dura, there's engorgement of the venous sinuses, and there's this large pituitary gland, and that entire dura also is enhancing, even because of the CSF into the cervical spine as well. But none of that is really happening there. Although there is some degree of tonsillar drooping, but it is not to that extent as that the tonsillar drooping you get in spontaneous intracranial hypotension. So it's very rare to have a true Chiari malformation with that peg-leg flattened tonsils, and like sort of a normal appearing cerebellar tonsil just going below the level of the plane of the foramen magnum. The only problem that will occur is that if the spontaneous intracranial hypertension does not, as in this instance, cause effacement of the pontomedullary angulation. That is somewhat of a deregulator to find that this is the case of spontaneous IC, intracranial hypertension. But sometimes I don't see it, and then that may be the reason why the patient will say, okay, this looks like a Chiari, but not. But then there are other ancillary findings of the enlarged pituitary gland and the distended dural venous sinuses. So I just don't understand where the confusion should come in case if you're interpreting as a neuroradiologist that this patient has got spontaneous intracranial hypertension. I guess that's a different lecture altogether, and I think it will be covered up later on by other experts. But it's an easy differential, and this was the recent sort of a table which actually clearly showed how to diagnose that. And then there is there are so many of these points which I mentioned previously that like brain sag, absence of a syrinx, and presence of subdural fluid collections or pachymedullary enhancement, all which are very easy to look at and to make a diagnosis. So sometimes it becomes a sitter, like, okay, here's the conundrum of this patient who's got XYZ symptoms. The patient has got vestibulocochlear symptoms or has eye signs, and lo and behold, pachymeningeal enhancement and involvement of the transverse sinus. Okay, here comes spontaneous intracranial hypertension. On the contrary, there is the idiopathic intracranial hypertension in Chiari. Now, this is another issue where there should not be much of this thing. If you look at the modified Dandy criteria for idiopathic intracranial hypertension, there should be absence of any deformity, displacement, or obstruction at the ventricular system, or otherwise normal neurodiagnostic studies. So there should be no issues here if you look at the strict interpretation of the modified Dandy criteria. I mean, this has been going on for many, many years. But the presentation is so typical. Here is a typical female, very short statured, has papilledema, has visual changes, and has pulsatile tinnitus, and has an intractable headache, who comes to the ophthalmologist for blurring of vision. So here the thing shifts, and then when you're looking at that, then you said, okay, yeah, it looks like it's intracranial hypertension. Patient will require some degree of imaging just to do an LP, look at the opening pressures and see if the pressures are raised. Take a large volume of CSF out, look at the closing pressures, and the pressure will definitely noticeably fall from, say, around 35, 36 centimeters of water to around 18 or 20, depending on the volume of CSF taken out. And then, of course, there is always this history of acne treatments, oral contraceptives, and any pre-thrombotic states which would sort of predispose these patients for development of dural venous sinus thrombosis. So dural venous occlusions can occur because of even electron granulation, and there could be thrombosis or increased intrasinus pressure because of that, and that sort of impairs the CSF flow. And then there is this other concept of some cause of raised ICP, which causes extrinsic compression of the dural sinuses, and then causes caudal descent of the cerebellar tonsils, which is, for me, it's kind of a big long shot. I mean, I'm just looking at an ordinary neuroradiologist, and I see that sort of a potential cause really requires some degree of imagination. Then there is this one concept which is coming up in the literature of aberrant CSF flow associated with the CSF malformation causes hypotension, and that leads to intrinsic intracranial hypotension, which leads to elevated extrinsic compression of the venous sinuses, and then and this sort of a tonsillar descent leads to elevated ICPs. I mean, the jury is out there for this particular concept, but this has been described, and there's and there is a whole chapter in one of the neurosurgical clinics just based on this concept. So now here is the idea of how this actually took place. There were these 43 patients of intracranial hypertension, and 9 had these peg-like tonsils in this particular series by Aiken. And there is, if you look at the images that have been provided, you will look at it very critically, and you'll notice that at least 2 of those images do have platybasia. No, I mean, I don't want to delve into the controversies about looking at a global perspective of Chiari 1 malformation in these particular instances. But the moot question here is, what is the incidence of intracranial hypertension in Chiari 1 patients? Right, the opposite. If you look at 1,000 Chiari 1 malformations, you may or may not see even 1 or 2 which are presenting with intracranial hypertension. So that is the thing which has to be answered, and that is not yet answered by any degree of population studies or epidemiology. So, so there was this new paper which I read with great interest from Professor Ides, and this showed that there was comparable elevated pulsatile ICP indicative of impaired intracranial compliance, both in CMI and IIS cohorts. I mean, are we dealing with something very specific, or it's a very non-specific finding? Is very difficult for me to interpret in all the results which I have. And this is a sort of a ongoing conflict in my mind as to whether or not I should be looking for this in every patient of Chiari 1 malformation. But I let the jury rest here. So then there is another concept which is close to my heart, and which everyone looks at, but nobody really comments upon, is looking at the venous anatomy in Chiari 1 malformation, especially in case it's a syndromic presentation of Chiari 1, and you have a venous abnormality like presence of the low-lying torcular or dominance of the transverse sinuses or large emissary veins, which can sort of come in the way of doing a very good suboccipital craniotomy. And there are some instances where literature has been very eloquent about small and tight posterior cranial fossa, but a swathe of neurosurgeons, both here and in India, have told me that they don't find any issues with a tight or small posterior fossa, and neutral position of the head while doing suboccipital craniotomy in the prone position would be adequate. And moreover, this is beyond my pay grade, that the evoked potentials and wanting during positioning and during surgery is important for and is coming in a very big way for all surgical specialties, especially if you're dealing with brain and spine. So what is the basis now? Where are we now with the radiology of Chiari 1 malformations? So here is the recommendations for the CNS regarding diagnosis, and this I think can be taken up as, because it has been done by a extensively well exposed group of neurosurgeons who are masters in their own field. And what they recommended for diagnosis was that in patients with Chiari 1 malformation, further imaging of the brain and spine will be helpful to evaluate any relevant pathology such as hydrocephalus and stable slings. So the first thing, if the patient is diagnosed with a Chiari 1 malformation, is to always get a baseline total spine done together with the MR of the brain. And that recommendation is grade C and a level 3 evidence. That means it has been gathered over a period of time with several reports in the literature. Then in Chiari 1 malformation, cine MRI or like cine flow MRI may or may not predict any benefit from surgical decompression. And measurement of the clivoaxial angle, PBC2 or C1C2 vertebral alignment may predict future insights into craniocervical instability and may need requirements for surgical stabilization. Again, these are all pooled data from multiple sources. Then what is the natural history of Chiari 1 malformation? Like this was pointed out by Dr. Limbrick too. There are no universally accepted criteria for selecting patients for CMF for surgery. And if these patients who are left over for just being followed up, it is going to be a very benign course without much change in the overall condition of the patient, even if the patients are managed conservatively. So what's missing in this? Complex Chiari is missing, and I think Dr. Brockmeyer is going to be an expert on that field. It's an excellent paper he wrote with Dr. Spader in 2015. There is a very good algorithm for this. I've deliberately not touched on syrinx and related hydrodynamics. I have not touched on glymphatic system, which is the current flavor. I haven't touched on cranial stability because radiologists don't usually come into the picture unless the patient is symptomatic and has developed some issues or have antecedent changes in the craniocervical junction for measuring that vertical instability. I have not touched on the syndromic applications or syndromic correlations with Chiari 1 malformation. There are obtained number of hypotheses about mesodermal issues, developmental issues and embryological issues, which I have not touched upon. And of course, genetics is not my forte, and any errors and omissions are exempted in my presentation. Thank you for your attention.
Thank you very much, Dr. Babaraj, for that excellent and very deep and broad treatment of the radiology of Chiari, which is very, very useful for us as neurosurgeons. Can I please invite Dr. Elias Risk to first ask the question and then Professor Klein? Thank you, Dr. Risk.
Thank you for this comprehensive review. Super deep dive. I don't know. I'm left speechless. I don't have any specific questions regarding this comprehensive review. I like the outfit though, the Michigan maize and the blue. That was a nice touch. Sorry for your loss yesterday, but yeah, thank you so much for this wonderful review.
Thank you, Dr. Elias. Professor Klein? Do you have any?
Yes.
Thank you.
Thank you very much for this very, very nice talk. Carefully looking at coronal imaging is very important, as you pointed out. And I'm sorry, do you hear me?
Yes.
Okay. And I have a question. It's a real question, so I need your help. What is your opinion about the shape of the tonsils? At least to my opinion, when the shape is triangular and not convex, the tonsils are more likely to impair CSF circulation. And here again, at least to my opinion, the 5 millimeter criterion is probably not sufficient in the definition of Chiari malformation. What is your opinion about that?
Yeah, so in my practice, I always will look at the abnormal shape of the tonsils. That's very important. That abnormal shape is something like what is defined as peg-like. Pegs can be of different shapes, but it has to be flattened. It has to be dysmorphic. It has to descend. It lacks the inferior aspect of that cerebellar tonsil should not have a rounded appearance. And that pointed appearance is, invariably abnormal. It invariably is symptomatic, and invariably is associated with CSF abnormalities. So that is true that a rounded inferior convex shape of the cerebral tonsils is always taken with a pinch of salt. And I always call it as a low-lying tonsils. And, usually when the patient comes in, and when I mentioned in the report, the surgeons also will agree that, it's better to put on conservative management and then come back and see it after 6 months or not if the patient is developing anything more sinister. Having said that, the idea for operating, when it becomes a little bit of a concern for me is to have that abnormal tonsils, look at the spinal cord and see if the syrinx is developing, and look at the clinical history of the patient if there are any fixed neurological deficits. Once these three things are present, I think it's time for surgery. Thank you very much.
Okay. Thank you, Dr. Barbara. Professor
Thank you very
Brockmeyer,
much.
also, thank you. Thank you, Professor Klein. Professor Brockmeyer, do you have any questions for Dr. Barbara? Thanks.
No questions. That was a great overview. Thank you.
Thanks. Dr. Jallo, do you have any questions?
No, thank you. I mean, it's an excellent presentation and very comprehensive. Thank you for sharing.
Thank you. Thank you so much, Dr. Barbara. I will, I hope that you will give us permission. I hope you have permission for this to be put on the YouTube so we can go through it and if you have any questions, I'll send it to you, and if you're kind enough, you'll answer to them. Thank you, sir.
Thank you. I'm on clinical service, so I need to leave. And thank you for your attention. It was a great pleasure to address this gathering.
Thank you very much. Much obliged. So the next lecture is from Dr. Aisha Christian. Dr. Christian is a consultant neurosurgeon, pediatric neurosurgeon at the Sick Kids at Toronto, and she's going to talk to us about patients with Chiari with hydrocephalus and those with intracerebral changes in intracerebral pressure. Thank you, Dr. Christian.
Hi, everyone. Really appreciate being invited to speak today. Let me just try to share my screen here.
We can see it just to maximize, otherwise it's coming through nicely.
Just trying to.
That's great. Thanks. It looks good, Dr. Christian.
Okay, great. Yeah, I'm just trying to minimize the Zoom on my screen, but great. So, hi, everyone. Great to be here. And that was a really great lecture. I think I know Dr. Naren asked me to include a little bit on the time slip imaging at the end, but I'm mainly going to speak about just the management of hydrocephalus and intracranial hypertension associated with Chiari, and then briefly also talk about some cases associated with intracranial hypotension and what the management pathways are. I don't have any disclosures, and we'll start with hydrocephalus and Chiari malformation. And I know Dr. Limbrick mentioned Hans Chiari, who first described the Chiari malformation in the 1890s. And really, the description of hydrocephalus and Chiari were first mentioned by him. And if you look at one of his first publications in 1891, it actually translates to cerebellar changes caused by hydrocephalus of the cerebrum. So in a lot of ways, this theory of hydrocephalus causing the Chiari malformation, that was the original hypothesis in the 1890s. This came from a case report of a 17-year-old girl with typhoid fever, essentially, and Hans Chiari had done her autopsy and found this caudal descent of the tonsils with ventriculomegaly, and essentially this is where that hypothesis began. So the simple hypothesis, which we all know doesn't fully or even explain majority of Chiari malformations, is essentially pressure from above. However, there are a lot of other things with Chiari that we now know that negate this simple hypothesis. And even though it may be true for a certain percentage of Chiari malformations, if we look at studies, we see that anywhere from 6 to 25% of patients with Chiari malformation have ventricular dilation. And I would say most people say about 10%. Therefore, a vast majority don't have ventricular dilation, and therefore this theory wouldn't hold for the rest of these patients. And then if you look at patients who do have Chiari secondary to hydrocephalus or any other cause of intracranial hypertension, for instance, with tumors, you do tend to see some of this reversing when the hydrocephalus or the tumor is treated. But then again, not all of these reverse as well. And then you have a more complex hypothesis that's been described over the years, and many different theories. Again, not one explanation but one involves a hypoplasia of the occipital bone that happens during development, which essentially leads to overcrowding of your neurovascular structures, neural tissues, could potentially lead to hydrocephalus as well. And the other facts or findings that you can see that are associated with this are things like basilar invagination, your instability of the upper cervical spine. All of these go along with this hypothesis that there's some type of issue with the actual bone that goes on during development. You see this with syndromic craniosynostosis. That's thought, the hydrocephalus here is thought to be an occlusion of the jugular foramina with a decrease in CSF resorption. And you also see this in non-syndromic Chiari malformations, where this is thought to be more of an occlusion of the actual CSF pathways. And then again, this theory doesn't explain everything, because when you go back and look at Chiari patients, not all patients have a small volume when you look at the radiology and you try to calculate their volumes. So trying to break this up piece by piece, one is looking at patients with a smaller volume, so a cephalocranial disproportion. And I think one classic example is craniosynostosis. If you look at craniosynostosis patients who have Chiari malformation, the two main syndromes you think about are Pfeiffer and Cruzon. And now basically Chiaris have been described in up to 70% of Cruzon patients with craniosynostosis, and in Pfeiffer's almost half as well. But then if you go back and look at craniosynostosis and hydrocephalus, this percentage is much less. You only see about 12%. And then you go one step further, you take patients with complex craniosynostosis who do have hydrocephalus, this 12%, 88% of them do have a Chiari malformation. So again, a lot of things that are interlinked, but not completely explanatory of each individual diagnosis. So going again into the complex hypothesis, one idea is that there's this possible progressive blockade of CSF flow from the cranial to spinal compartments, and there's this occlusion of the fourth ventricle foramina. Now, is it primary? Is it secondary? These can also be debatable, and there's also description of an occlusion of the cisterna magna as well. So to summarize, and again, I've put this reference at the end because I think it's a great paper that summarizes the different hypotheses of Chiari and hydrocephalus. We have the simple hypothesis that goes back to Hans Chiari with just a primary obstruction of CSF flow leading to hydrocephalus, and then a pressure from above theory, which causes the Chiari malformation. Now, the complex chart's much more involved. You can see it could involve this jugular foramina and the neurovascular structures causing venous hypertension that could cause the hydrocephalus, or leading to more of a cerebellar hyperplasia almost, or edema, and leading to, again, a disproportion of your cephalocranial volumes with overcrowding, again, leading to the Chiari malformation. And then with the Chiari, you get impaired CSF circulation, which causes hydrocephalus. So again, a lot of different pathways, some interconnected, which I think make this a complex problem and difficult to treat, because all these theories don't fully explain the association between hydrocephalus and Chiari malformation. So again, as I mentioned, the challenges then become how do you treat these patients? The chicken or the egg, which comes first? One, we don't have a unifying etiology, so this complicates treatment decisions. You don't have a kind of a simple pathophysiology. There's different variations of Chiari, how they present, severity of symptoms, and again, multiple theories exist. None fully explain the conditions. They are interconnected, and you get variable patient presentations. And therefore, treatment really requires a more personalized approach. So one is the big question, do you treat the hydrocephalus or the Chiari? And I think this is, even though most of us say treat the hydrocephalus first, I think this is still up for debate. I would say most surgeons tend to treat the hydrocephalus first. It's more symptomatic often. It does address the syringomyelia. It eliminates any concerns for high intracranial pressure. And if you treat Chiari, do duroplasty with hydrocephalus in the background, you could get complications of CSF leak and postoperative pseudomeningocele that you would like to avoid. Now, the one exception to think about is syndromic craniosynostosis. When there's an obvious craniocerebral disproportion in these patients, do you treat the hydrocephalus or Chiari? And I would say most would say consider vault expansion in infants and posterior fossa decompression before you manage the hydrocephalus, because the hydrocephalus helps you with expanding volume, essentially. Now, once you decide you want to treat the hydrocephalus, then the question is, do you shunt or do you do ETV? Now, we think about 10% of Chiari patients have hydrocephalus. Now, this is a paper from 2011, small series of patients, but one of the first that described ETV in the management of Chiari-1 related hydrocephalus. And in this very small series, all 15 responded to ETV. Now, since then, 15 is a small number. So looking at this in more detail, there was a systematic review that came out last year that essentially did a pooled analysis of 35 cases of Chiari malformation and hydrocephalus treated with ETV. And they did find about a 66% symptom response and improvement. And then radiographically, there was definitely tonsillar descent reduction, decreased ventriculomegaly, and almost all patients had open ETV. Now, if you really look at the details of this paper, though, there's a lot of variation in patients. Several did need repeat treatment as well. So again, I don't think we have all our questions answered at this moment if in terms of management. But avoiding shunt obviously is great if there's anywhere over a 50% chance of response. And so I think ETV has become a favored method of treatment for this. Now we do have surgeons still doing shunts. And again, this is another paper that came out in the last 5 years, just really a case report on an infant with Chiari-1 malformation, hydrocephalus with quite symptomatic, and essentially all these symptoms did resolve with a VP shunt treatment and no decompression needed. So the next step is to talk a little bit about Chiari malformation, hydrocephalus, and syndromic craniosynostosis, because again, this would be the exception to the treat the hydrocephalus first rule. And if you look again at craniosynostosis and Chiari, Pfeiffer and Cruzan are the two syndromes you do see more of Chiari-1 malformations. It's very rare to actually see this in APERT. And then if you look at craniosynostosis and ventricular dilation, again, similar numbers in Pfeiffer and Cruzan, and APERT also having a high percentage of ventricular dilation. But I would say the key difference is in APERT, they're non-symptomatic ventricular dilation, not requiring treatment, whereas in Pfeiffer and Cruzan, the ventricular dilation ends up being symptomatic and requiring CSF diversion at some point. And then the other key, I think, when you're managing these patients is to look at their signs and symptoms that they're presenting with. Are they symptomatic from the Chiari or are they symptomatic from the hydrocephalus? Now, again, I did mention that in infants, especially, most people prefer managing the craniosynostosis first and increasing volume and doing a potential Chiari decompression at the same time. But as these kids get older, and have signs and symptoms, it's key to differentiate, are they having high pressure symptoms or Chiari symptoms in your next steps for management. So with hydrocephalus, again, the things to look for, and I know that previous talks have long lists of both of Chiari symptoms as well, but with hydrocephalus, you're looking at drowsiness, vomiting, head circumference increase, and bulging fontanelle, and sunsetting in infants. And obviously headaches in older and papilledema in older children. With Chiari, again, the list is much longer than what I've included here, but these are the ones to consider in being more of a Chiari type problem than a hydrocephalus issue. So treatment, again, in general, most people tend to treat craniosynostosis and then monitor ventricular size. I would say consider ETV as well. There have been some evidence showing that if they're over 6 months, the response rates in this patient population are better. And if there's evidence of foramen magnum obstruction on MRI, then those patients have a better response rate to ETV, but again, very small numbers. And then in shunts, the recommendation is to use programmable shunts because their hydrocephalic needs do change, and especially in terms of developing syrinxes and syringomyelia, there's been some preference for use of programmable shunts, but again, very small amount of data. In terms of Chiari treatment, again, the craniosynostosis in infants with a posterior vault expansion, with or without a posterior fossa decompression at the same time. And I think most advocate early vault expansion for multi-suture craniosynostosis. And then in older children, because of the high risks of vault expansion and delayed diagnoses, you can consider just doing a Chiari decompression. And again, as I mentioned before, lots of challenges with this. I think a lot of these papers have small numbers of patients. And I think there's still more to be done in terms of finding an optimal management pathway for hydrocephalus and Chiari malformation. Now, the next thing I'm going to briefly talk about is Chiari malformation and intracranial hypotension. So this is another theory in terms of the etiology of Chiari malformation. This is a paper back in 2009 that describes acquired Chiari malformation as a late complication of CSF shunting. The theory or the idea is that this chronic removal of CSF leads to an intracranial hypotension, that there's progressive inner bone deposition of the skull. And with this, there's a decrease in skull volume that basically leads to Chiari malformation with downward herniation. Now, this paper describes 17 patients, and now this is out of 1,700 patients with a Chiari. Only 9 were symptomatic, and they did rule out a shunt malfunction as well. But I'm sure all of us have had patients with shunted patients who have developed Chiaris over time when you go back and look through the imaging. And this is again, if you look at the bone, and I'll show some pictures later on, there is this deposition and thickening of the skull that you do see with these patients. That's typical. So this is one case example of a patient that had an arachnoid cyst, no Chiari malformation. The top row here is pre-intervention. Then you see row B, essentially, this is after the patient was shunted. You start seeing a little bit more tonsillar descent. And then row C and D, essentially, C is pre-op, but you see this, again, thickening of the bone, which you start seeing actually in B as well. And you see a Chiari essentially on the sagittal imaging. Now, this is post-op because this patient was symptomatic and went on to need surgery and decompression. But again, the thickening of the bone, quite typical. This is another case study. And again, you see hydrocephalus, no Chiari on A. You look at B, you see a dramatic thickening of the bone, slit ventricles. Now you see a Chiari. And then again, example 3, same thing, hydrocephalus in A, treated hydrocephalus, the tonsils look a little lower, and you see the cerebellar is taking up more volume, and then essentially thickening of the bone over time with Chiari malformation. So management for this, you could do multiple things, and I've again small series of patients that have been described in the literature. I think the typical is to do a Chiari decompression and duroplasty. There's small case series of some surgeons who've decided to do a cranial vault remodeling. But obviously very difficult in older children. And then there's a small set of series describing a Chiari decompression duroplasty, and then essentially a thinning or down of the occipital planum and a remodeling in just the occipital region, with the bone being replaced once it's thinned down. The second example of low pressure and intracranial hypotension and Chiari development is with lumboperitoneal shunts. And again, you have drainage of CSF in the lumbar region, leading to a downward motion of movement of tonsils due to a pressure differential theory. And this has been described with lumbar punctures as well, repeated lumbar punctures. And classically, the management's essentially been the removal of the lumboperitoneal shunt, insertion of a VP shunt, and then if this fails, ultimately leading to a Chiari decompression and duroplasty if needed. I know I was asked to briefly talk about imaging, which I know we had a very detailed lecture on, so I'm going to go quickly through it. But a lot of detail on the cine phase contrast MRI with our last talk. And specifically to talk about the timestamp MRI, looking at CSF motion, because this was just published a few months ago. Now, I actually trained with Gordon McComb at CHLA, and I know he was working on this more than, I think, 15 years ago when I was a resident at CHLA and Children's Los Angeles. And essentially, he worked with the radiologist and physicist on a timestamp technique for looking at CSF motion around the foramen magnum and also at the floor of the third ventricle. And again, there's always been an understanding that there's an obstruction of free movement of CSF across the foramen magnum, especially during systole. And the timestamp, I think, takes advantage of this. And again, I think physics of it are a little bit beyond my understanding, but it's a very short protocol. It's about 7 minutes. It's on a 3T scanner, and they ask for fast spin echo sequences that are about 4 millimeters thick. And essentially, there's CSF tagging that's done during the MRI, and it's quite easy to process, is my understanding. They had several case examples they highlighted in this paper, but one was a 15-year-old with suboccipital, again, post-Valsalva headaches. And you can see the timestamp on B that basically shows no flow around the cervicomedullary junction. And I think you can appreciate this on the T2 sagittal as well. But after surgery, there was a complete resolution of the headaches. Now, case 2 is a 3-year-old with a Chiari and syringomyelia who presented with neck pain and bladder complaints. But again, you can see with the timestamp on the pre-op is here in D, very minimal flow, and post-op, 3 months post-op, you can see that there is flow around the foramen magnum and improvement of the syrinx as well. And then case 3 is a 16-year-old Chiari incidentally diagnosed after head trauma imaging. He did state that there was a history of headaches for about 6 months, but given that there seemed to be good flow around the foramen magnum, the decision was made to observe. And when he followed up in clinic, there were no headaches several months later. And so, again, just some nice case examples of how this has been helpful. And my understanding is they're easier to acquire than the CNA phase contrast and interpret as well. But again, it's just briefly, just very challenging, I think, in terms of the best way to manage these patients. And I think they really require a more personalized approach in terms of managing the hydrocephalus and Chiari. And I don't think there's necessarily one pathway forward, even though a majority would say manage the hydrocephalus first, with the exception being in craniosynostosis. Some references that were helpful, and that's it. Thank you.
Thank you very much, Dr. Christian, for that fantastic talk, unpicking the overlay of hydrocephalus and pressure in patients with Chiari, which sometimes doesn't come apparent in the first look because the eyes go to the tonsillar descent. I'm going to ask our faculty for this session, Professor Llewellyn Paediatric. Dr. Paediatric, your comments on the lecture and your questions for Dr. Christian. Thank you.
Thanks, Naren. I think that was just a fantastic overview. The last one and the previous ones by Dr. Limbrick and the radiologist. So I'll ask Dr. Christian. I mean, this issue of asymptomatic or incidental Chiari is something we all have to contend with quite a bit. So to what extent, and how do you look, asymptomatic is very different in different practices. So the harder you look, the more you'll find something. So we heard about hydrocephalus, we heard about intracranial hypotension. The other thing is, imaging the entire spinal axis to rule out tethered cords. We heard earlier that some do, polysomnography. To what extent do you investigate your patients, before you call them asymptomatic is my question. No, thank you so much.
So I mean, I personally follow them, not for their entirety if they're teenage years, but they at least get one follow-up a year later. They do get brain and spine imaging as well to look for syringomyelia and a full exam. With the sleep studies, I find our wait lists are quite long, to be honest with you. So it would be very hard to order a sleep study because I do see a few Chiari patients almost every week. So I try to ask them questions about the sleep disorder, any changes in sleep with parents and things like that, and go from there. But I agree. I think it's tough, and I think the headaches are the hardest to distinguish what's really Chiari related and not.
Okay, Llewellyn?
Yeah, no, thanks. Look, that's always a tough one. I know there isn't an answer. It's just wanting to see to what extent. I mean, I've also heard people doing SSEPs, which in an awake patient is really, really unpleasant. So just the extent to which one investigates them. Thanks so much. Thanks, Nam.
Thank you, Professor Llewellyn Paediatric. Professor Brockmeyer, do you have any questions for Dr. Christian?
No, Isha, that was a great presentation. I think that the syndromic craniosynostosis population and how it connects with Chiari is really poorly understood, and I really appreciate your thoughts about that and the vault distraction techniques rather than the posterior fossa techniques. So I think we don't know a lot about it, and it's an understudied population. I don't know if you have any other thoughts about that.
I 100% agree. I think I didn't realize that till I went out in practice and I was starting to see a lot of this. And then the issue becomes, are they symptomatic? I think the key is, it's a hydrocephalus issue or this Chiari issue. And I know in some cases I've had to do pressure monitoring, ICP pressure monitoring. But those patients I find, especially Cruzon, can be a lot of variation in presentation. I'm a huge fan of trying ETV as initial management. I think after the vault, because just letting the ventricles get bigger actually helps with volume. And then if I can, I try to reach down and decompress the foramen magnum at the time of the vault as well. And I've had patients do well with that.
Thank you, Dr. Christian. Dr. Jallo, do you have any questions for Dr. Christian? Thanks.
No, thank you. The question, how often do you place an ICP monitor to help determine whether it's ICP versus the Chiari as the etiology for their symptoms?
I think if they, if they're having papilledema, it's, I don't necessarily place an ICP monitor because I feel like that's more of a pressure issue. But if I'm not quite sure and they're having combination of both, then I have. But again, it's been a couple, maybe one or two over the last 7 or 8 years, so not commonly.
Thank you. Dr. Risk, do you have any questions? Dr. Risk?
You mentioned about treating the hydrocephalus first. There was a paper from Benny Iskandar a couple of years ago that showed in his cohort at least that 90% of the time if he does the posterior falsetto compression with and without uroplasty, then it's to improve the size of the ventricle. It's the symptom of the statement. It tells me that we have to do something. I don't know if it's the chicken or the egg, but there is some form of obstruction that has to be managed. Yes, I know, ETV and the appropriate hands can be safe, but also some of our colleagues, especially on the health side, are very uncomfortable with some of the ETV procedures. So to me, at least, something has to be treated rather than just recommended one entity versus another, and also highlighting the lack of recent data on this information. The call to at least start to look at some small outcomes of average certain pathologies that can be done at a very wide level, bringing our colleagues here and an effort that should be undertaken at some point is that it's and
Dr. Risk, we had some difficulty catching the sound thing. So I think Dr. Christian, did you catch Dr.?
I might need you to repeat the last part, but I think there's just treating maybe the Chiari decompression, doing that first versus the hydrocephalus, and that there's not enough maybe data that we still don't quite understand what the right steps are. Is that, I think that's what I heard, but if I didn't.
Yeah, what I'm alluding to is that treating something will result in a better outcome, be it Chiari first or the hydrocephalus in a hydrocephalic patient, because both entities might end up treating or helping the patient. The paper that Iskandar put out a couple of years ago, showing that in his cohort, the posterior falsetto decompression with or without uroplasty tends to resolve the hydro in about 90% of the patients. Is a point I'm making that sometimes people are not comfortable doing ETVs or putting shunts in off the first evaluation. So you could still consider that as an option. It's not like, it's absolute, especially in the lack of concrete good data, and a call to us as a community to start looking at this stuff in a much wider patient cohort rather than 19 patients or 2 patients here and publishing it in the literature.
No, 100%. I think that's the big thing. I don't think there's a right answer. I don't think we completely understand it, and it just needs to be studied more.
Thank you. Thank you, Dr. Risk. Thank you very much, Dr. Christian, for that really fascinating and insightful lecture. Dr. Christian, there are 3 questions for you on the chat box. Because of the time, may I please ask you if you would answer them on the chat box, please. Thank you again.
Definitely. Thank you.
Thank you very much. The next lecture is from Dr. George Jallo. Dr. Jallo doesn't need introduction to the listserv community and to pediatric neurosurgery. He's the he's the vice chair at the John Hopkins All Children's Hospital and the chief physician. Obviously, he's a neurosurgeon with a distinguished career, and he's going to give us a talk on controversies in Chiari, pediatric Chiari. Thank you, Dr. Jallo.
Naren, thank you. And hopefully everybody can hear me and see the presentation as well. And as Naren stated, I really just want to share my thoughts on Chiari malformations and some of the controversies surrounding this entity. For disclosures, I have none to declare. And really, I'll start off with an illustrative case that I had to manage about a year ago. It's a 14-year-old girl that presented to the hospital with fevers and some lymphadenopathy. You can see the CAT scan there. And the concern was that she had mononucleosis. However, the radiologist astutely read a Chiari malformation on this CT scan with a syrinx. During her hospitalization, the MRI was performed, and you can see the MRI there. Clearly, the tonsils are below C1, and she has a cervical syrinx from about C2 down to C4. There's no evidence of tethered cord on the complete spine imaging. On examination, she was asymptomatic, no headaches, no visual complaints, no gait instability, sensory or any motor deficit that was appreciated. And one does appreciate all the lymphadenopathy that she has. And I did see her in the hospital. And given that she had an acute viral or syndrome, recommended really just to follow up in the clinic in several months' time. And we'll discuss the management in terms of what would someone recommend. Would you recommend surgical intervention, observation? If it is observation, how often would you follow her? My recommendation initially was to come back in 3 months with a repeat imaging study. So really, there's some concerns and questions whether, is it a malformation or is it deformation? I think we heard a little about this in Dr. Limbrick's lecture. What is the etiology for the hindbrain progression? I think, the subsequent lectures discussed this. Is there a concept of supratentorial crowding, small posterior fossa? And in terms of treatment modalities, is there a single algorithm that best manages this entity? And I think, in terms of natural history, just sharing again the contributions that Hans Chiari had in the 1800s regarding the diagnosis of this condition. We had a great lecture on radiology as well as some mention of this. As I was reviewing the literature on this, and the radiographic definition of the Chiari malformation. I think the first papers I was able to identify were in the mid-1980s, 1985 and 1986. And really, in the first paper, it's recommending that MRI is the diagnostic modality of choice to identify a Chiari malformation over CT, X-ray, or at that time, pneumoencephalograms or CT myelogram. And I think really astutely at that time, the radiologists recommended that the symptoms of Chiari can overlap those of a demyelinating disease. Interestingly, this is the paper that defined the descent of the tonsils as a Chiari malformation rather than physiologic or ectopia. And again, it was really based on 0.15 Tesla magnets. And clearly, we've come a long way since that time. And in this paper, really, what they found was that In the exceptional case, that the normal position of the cerebellar tonsils may be 3 millimeters, and borderline cases are somewhere between 3 to 5 millimeters below. However, tonsils below 5 millimeters most likely suggested a Chiari malformation, and that really invasive radiographic techniques such as CT myelography was no longer needed. So, I think what are some of the appearances on MR? And, we did, this was really well presented in the previous lecture with the peg-like appearance, effacement of the CSF, a flattened occipital bone, venous engorgement, the tentorial slope, as well as the occipital lobe, being posterior to the cerebellum, as identified. And in terms of the pathology, clearly, the tonsils are typically below the foramen magnum, and very unusual. I think it's rare. I don't have an exact incidence where you tend to see the tonsils below C2. And then the associated hydrocephalus is uncommon. However, there is the associated abnormalities of the skull-based basilar invagination, and that syringomyelia, as well as scoliosis, can be found in this population. So the first controversy, and I'm so glad to see Professor Toole here, is is it a malformation, or is it a deformation or a formation? I think we all should um, read his editorial in 2017, changing where he advocated for changing the name from a malformation to a formation. And Professor Toole, I think you can comment, but really, I think that the theory behind this is that congenital malformations are structural or functional anomalies that occur during intrauterine life, and that these conditions develop prenatally and may be identified before or at birth, or sometimes later in life, and that these malformations do not grow or progress, whereas a deformation or formation, on the other hand, is an action or a process of deforming or distorting a structure or its shape, including flattening, or elongation, and that they can be a result of external forces over a period of time, and these deformations can be progressive, stable, or regress as the forces that act on the structural change. And clearly, I think that is the case with these Chiari malformations, is that there's a change. Some do remain stable, other progress, and others regress. And we've all seen that, and we've seen the papers regarding this. So should a Chiari malformation be termed a deformation? And knowing that the cerebellar tonsil descent through the foramen magnum is not congenital, and that and if congenital malformations are static and not progressive, should we redefine the terminology used to describe these? And I will leave that open for discussion at the completion of my presentation. And so what are the possible causes? Could it be the supratentorial crowding, that the tonsils are that it's not that they're growing taller, but they are being pushed down or stretched thin from above, and this is in the presence of the small posterior fossa. And I think others have recognized this as calling it a Chiari malformation 0, and or the Chiari malformation 0.5. And then is the Chiari deformation or downward stretching of the posterior colons, is that the presence? And the other is the small posterior fossa that's associated with some of the other skull-based anomalies, such as basilar invagination, platobasia, cervical instability, and then ventriculomegaly. We heard from Dr. Christian about hydrocephalus and Chiari, and it's really what causes what. Does the Chiari cause the ventriculomegaly? Is it the descent of the tonsils that leads to an obstruction of CSF, and an obstructive hydrocephalus, as well as a potential blockage of the foramen magendium or is it that that they're both in play and it's a potentiating cycle? I think there's several papers that were mentioned. I think the most one of the recent papers that shows that that children with hydrocephalus or ventriculomegaly and a Chiari should be treated, as we heard earlier, with a CSF diversion rather than the Chiari decompression first. And clearly, in this recent paper, what they found was that the success rate for their series of a dozen patients was close to 93%, and that overall the length of the syrinx did not change. However, the diameter of the syrinx did improve, as one would expect if one completed a Chiari decompressive surgery. The other is in terms of, I think the diagnosis and the management and the presenting symptoms. I think this is a paper from the Oxford group on a review and really sharing their thoughts in terms of the symptoms, whether they were the general symptoms. They broke them down in general, which were like headache, cognitive fatigue, ocular symptoms, otoneurologic, such as dizziness, disequilibrium, pressure sensation, hindbrain symptoms, spinal cord symptoms, and you can see the relative incidence of these symptoms in their series, and in their algorithm, they really presented an algorithm for the primary care or the neurological physician in terms of making the diagnosis and the treatment algorithm or the diagnostic algorithm. I think this paper really summarizes the presenting symptoms. I know Dr. Limbrick spoke about this, whether it's the headache, fleeting headache, neck pain was probably the most prevalent in as a presenting symptom, scoliosis, and then the sleep apnea or bradycardia was seen in about less than 10% of their series of the review series. So, changing gears, what is the outcome? And I think Dr. Lemperk did discuss there's really no paper that shared the long-term natural history of a Chiari malformation. However, from the DC Children's Group, they looked at some incidentally discovered Chiari malformations and which individual child or a pediatric patient required closer observation or the need for surgical intervention. And as one expected, if there was the presence or absence of a syrinx warranted were typically operated. If a syrinx was present, almost close to 100%, 94% of the children at some point within their study follow period of about 10 years underwent surgical intervention. Whereas if a syrinx was not present on imaging, the chance of the likelihood of intervention was probably less than 5%. And they also looked at the extent of the tonsillar herniation or descent, whether it is between 5 to 9 millimeters or more than 10. And there really wasn't a statistical significance in terms of how low the tonsils were for the future need of surgery. So clearly, in their review, they found that incidentally discovered Chiaris, and these were children that presented with MR imaging for some other cause, whether it was a car accident or for some other imaging indication, that 85% are unlikely to require any intervention, especially in the absence of syringomyelia, and that really at the end, 16% had surgery and 10% occurred within the 6 months of diagnosis, and that there is a small subset of children that will undergo de novo formation of a syrinx and progressive neurological symptoms during this follow-up period that required intervention, and that syringomyelia was probably the biggest, was the driving force for surgical intervention, and the children that did not have syringomyelia were unlikely to require any intervention. So as I progress, when does a Chiari become a surgical disease? And really, an international survey found that if they're symptomatic, if the tonsillar descent was 12 millimeters or greater, if there was loss of CSF at the cranial vertebral junction, and if there was the appearance of a syrinx. And can any Chiari be treated by cervical medullary decompression alone? And I think, fortunately, Dr. Brockmeyer is going to cover complex Chiari because those are a formidable challenge with increased morbidity, and a simple Chiari surgery may not suffice. In these cases, surgery needs to be tailored to the etiology rather than to the Chiari decompression. So I think the most widely accepted surgical approach is to perform a craniocervical or craniovertebral decompression with or without a dural graft. And that it should be emphasized that the craniectomy should be small to avoid downward migration of the hindbrain into the craniectomy, and that the slumping phenomena of the hindbrain is a known risk. So I think the goal is really to achieve a reconstruction or reconstitution of the cisterna magna to improve CSF flow with the hopes of improving the syrinx size and allow the cranial ascent of the hindbrain on future MRIs. So, I think in terms of the treatment of Chiari malformations, and this is not an exhaustive list. I mean, I list, I think, 9 different approaches, but I can reassure you that these aren't the only 9 approaches. I think there's a little over 50 members here in the audience participating. There's probably 50 different ways to do a Chiari malformation. I think the standard is posterior fossa decompression, whether one opens the dura or doesn't open the dura. Open the dura, don't touch the arachnoid. Open the dura. Um, uh, Open the arachnoid, resect the tonsils, coagulate tonsils, duroplasty, no duroplasty. The question of whether or not one should, do a C1 laminectomy. Some have also advocated for C1, partial C2. Others advocate no foramen magnum decompression, just do a resection of the posterior arch of C1, open the dura and resect the tonsils with a duroplasty. So there are many different variations, or whether you call them variations, or controversy regarding the management of the Chiari. But I think really the key is, performing the procedure and minimizing complications. And many of the complications have been, are supported in the literature by as a result of opening the dura, doing a large occipital as well as a C1 and a C2 decompression. And then there's some increased complications with coagulating the the cerebellar tonsils. I think this is a large series, although it is both pediatric and adult, from Jorg Klemkamp. And really what they found was that that the morbidity associated with can be as high as somewhere between 2 to 5%, and that really opening the dura and manipulation led to an increased complication as compared to not opening the dura. And I think this is supported more recently by the Picori study looking at posterior fossa decompression with and without duroplasty. And what they found that although the risk of reoperation was higher when a duroplasty was not completed, just posterior fossa decompression, bone-only decompression, when a posterior fossa decompression with duroplasty was performed, there's clearly a greater risk of cerebral spinal fluid related complications, as high as almost 20% if one opens the dura as not opening the dura. And I think what's interesting is, as I was preparing for this, came across this paper, which compares a suboccipital craniectomy versus a cranioplasty. And again, this is both really a large series of 64 patients that both pediatric and adult. And what they found was that although the craniectomy group had a larger increase in subarachnoid spaces compared to the cranioplasty. The results of syrinxes in their series of syrinxes, the reduction in syrinx size was smaller, was similar. And the only finding that they found was really that the cranioplasty group on average cost there's significant statistical significance in the cost, almost doubling of the cranioplasty versus the craniectomy group. And you can see their treatment algorithm and their results there. The next question I think, is the question that Dr. Christian brought up is the series of children that may have syndromic craniosystosis with the Chiari. And in this paper, about 13 years ago, really what they felt that in children with syndromic craniosystosis and Chiari, probably the initial strategy should be on the cranial vault or the craniosynostosis, followed by a period of waiting and radiographic surveillance. And this was again similar to the Birmingham group that looked at their series of posterior calvalleal vault expansion using distraction osteogenesis. And Naren, I think you might have been involved in this group as well that advocated really for posterior cranial vault distraction in their series of both syndromic and non-syndromic children that had craniosynostosis and a Chiari malformation, and that the posterior distraction surgery both was a treatment for the raised intracranial pressures as well as a good treatment for their Chiari malformation in these children. And then, in terms of more controversy, is really, I think it's Professor O'Toole's paper about 7 years ago that really felt that, and I think it's the first time that we read about the Chiari formation rather than a malformation, where he identified three types of instability in 33 patients that had Chiari malformations, and the treatment was an allantoaxial fixation, and it treated both their instability as well as their Chiari malformation. And I will address this with Professor. And you can see the type 1 there, anterior versus the posterior, and the type 3 where there's really normal alignment, no evidence of instability, but a Chiari malformation. And what he found was, in their series, is highly successful not to do Chiari decompression surgery, but the allantoaxial fixation, which resolved both the Chiari, their instability, and the presence of a syrinx if there was one. The other question is, I think some controversies is really the use of evoked potentials during a Chiari surgery. In my practice, I don't routinely use neurophysiological monitoring, although this paper about in 2017 found that they did find that there were some electrophysiological changes that were evident during the operation. However, they did not add any clinical information in patients during the operation during the surgical removal. And this more recent paper found that really that there was no useful it was not a useful adjunct for surgery given their retrospective analysis over 100 patients, and really it did add a cost to the surgery, and that really that they advocated that the routine use of neuromonitoring should not be used during surgery. So I think, to just as I begin to finish up, I really just want to talk about complications. The CSF leak, pseudomeningocele, we heard about hydrocephalus, meningitis, cerebellotosis, instability, and paraplegia. I think from the PCORI study, the Park Reeves Research Consortium, really when they looked at their approach for the Chiari-1 malformation, and they looked at both whether an autograft was used, and they looked at their autografts was the pericranium in probably 95% of their autografts versus a non-autologous or allograft, where they looked at bovine collagen, a pericardium, an allograft, or a synthetic material. And what they did find was that there was that really the complication rates are similar when one does a duroplasty. However, there was a slight increased incidence of pseudomeningocele and aseptic or chemical meningitis when a non-autologous grafts were used, whether it was a bovine pericardium or the bovine collagen. Clearly, that was the highest incidence and the complications that was associated with it. And you can see in their tables the results of the individuals. So I think clearly, the question then came up in another study that looked at the duroplasty versus a non-duroplasty posterior fossa decompression. And what they did find was that there's really no differences between the groups for postoperative complications beyond the 6 months of surgery. However, the posterior fossa decompression group without duroplasty were more likely to require revision surgery. I think it was 18% versus 8%, and that the duroplasty group had a greater improvement in headaches and back pain as compared to the non-duroplasty group. But there's really no differences in whether in neurological examination and in terms of that. And I think you can see, in their tables, the incidences of complications was relatively similar in both groups, and I apologize for that. And however, there was a difference in the operating times and really the length of stay in the hospital. Your posterior fossa decompression with that duroplasty were tended to be discharged 1 or 2 days earlier than a duroplasty group there, and that really there's no time for revision. I think the question comes up of the headaches, and I know that came out of the Park Reeves group. We had looked at this when I was in Baltimore, and clear, I think what we did find was that that headache was more likely to recur than objective cranial nerve or brainstem symptoms following surgery for their Chiari. And really, what we did find was that the increasing length of preoperative headaches and vertigo, as well as frontal headaches, were more likely to result in recurrence of their symptoms as compared to other findings. And I think this was confirmed by the Boston Children's Group this couple months ago. And what they found was that really, regardless of the procedure, that in their study, they found no difference in the headache outcomes in really the children that had the classic or the fleeting headaches, but in children that had atypical headaches, they're more likely to have a recurrence of their symptoms or a lack of improvement of their symptoms following Chiari surgery decompression surgery as compared to the fleeting headaches that Dr. Limbrick. So I think if we just, as I close, bring it all together, I think, if one has confirmed radiographic Chiari, if they're asymptomatic, if there's a syrinx, I think they should recommend the circummedullary decompression. In the group that has no syrinx, really observation. In the patients that are symptomatic, is there presence of hydrocephalus? I would consider a CSF diversion ETV shunt. If there's no hydrocephalus, consider the circummedullary decompression. And if in terms of whether a duroplasty or a non-duroplasty, I will defer to the individual surgeon's preference. And if they become have recurrent or new symptoms or the presence or absence or the presence of lack of resolution of the syrinx or development of syrinx, really consider re-exploration with a duroplasty. I think there's a very small subgroup that may require a subarachnoid stent. If there's ventral decompression, I think these are complex and require reduction or invagination fixation. And I'm going to defer to Dr. Brockmeyer's lecture, craniosynostosis. Heard a little about this here as well as earlier about the cranial vault expansion. So going back as I close with my young girl that presented with the Chiari and that cervical syrinx, I did advocate for a decompression. She underwent posterior faucet decompression, C1 laminectomy without a duroplasty, did not open the dura. And then she was discharged home on post-op day 1. And the question was the timing of repeat imaging. I tend to repeat the images. I will get a baseline at 3 months after surgery, although I'm not looking for the syrinx to decrease in size. And then the next study is usually at the 12-month mark. And at her annual visit, her annual return visit, this was the results of her decompression surgery. You can see that there was some improvement in the shape of the tonsils, a little space, CSF space around the cerebellar tonsils, and a dramatic reduction in the syrinx. So hopefully, I think, as I conclude, clearly the ventriculomegaly, the hindbrain progression, the calvalular augmentation, and then the treatment of, the syrinx, and whether or not it should be treated or not, and what is the best treatment for this. So I do want, Naren, thank you for having me invited to speak today. And I'd also, I know there's going to be some controversies following this lecture, and I am looking forward to that lively discussion. Thank you so much.
Thank you very much, Dr. Jallo, on this very an excellent overview of the controversies and thought and provoking our thoughts. And may I please invite Dr. Professor Llewellyn Paediatric to comment and ask questions first. Thank you, Professor Paediatric.
Thanks so much, Naren, and thanks, George. As usual, it was just a fantastic, insightful talk. Perhaps just a question. So you mentioned motor-evoked potentials, in that context of adjuncts and, for positioning. We've done a few cases now where we've seen the motor-evoked potentials change just on positioning, so flexion of the neck. In fact, in one case, we actually saw it kind of disappear. The meaning of that is really difficult. But the context of adjuncts, so the use particularly something I've been quite keen on, ultrasound or some sort of intraoperative, quality check mechanism to decide whether the bony decompression alone is enough or, whether you open the dura. So we followed a kind of a treatment algorithm where we do cine flow CSF before, and if there's no CSF flow around the craniovertebral junction, then the ultrasound before thinking about opening the dura, if you see some flow with the power Doppler is useful. I mean, any thoughts, or do you use that, or any thoughts on whether we should, or if it's useful or not, George?
Yeah, wonderful question. I do use the ultrasound, but there are times where I haven't found it helpful. In my mind, I've made a decision beforehand if I'm going to go in and just do a bone-only or I'm going to do the decompression with the duroplasty. I use the ultrasound as an adjunct, and I will say it hasn't changed what my preoperative approach was in those children. But again, that's it might be just unique to my practice. Along those lines, I know there are certain groups that use intraoperative MRI for all their Chiari decompression surgeries, where they do the bone-only decompression, do an MRI, and then modify their approach based on the intraoperative MRI. And then along neuromonitoring, I don't use it in the routine Chiaris, but if there is evidence of instability or some anterior compression, or really, for my skeletal achondroplasia, where I'm doing a decompressive surgery, I routinely use neuromonitoring for those.
No, thanks, George. Thanks so much.
Thank you, Professor Paediatric. We have also the other faculty is Professor Ricardo Santos de Oliveira from Sao Paulo. Professor Ricardo, do you have any questions or comments for Dr. Jallo? Thank you.
Thank you, Naren. Thank you so much. And thank you, George, for this excellent talk. I think that Chiari 1 is the perfect topic to discuss controversy. It's a really, really amazing topic. Yeah, I think that you explore some very interesting points as in terms of terminology, clinical presentation, posterior fossa decompression, dura or open the dura or not open the dura, and finally, the primary and secondary Chiari. Yes, these are very exciting topics, but I'd like to ask to know what your opinion about the very controversial surgery, the filum terminal section. So, what is your opinion about it?
Corey, thank you. I must admit, I think that's extremely controversial. In my experience, I've seen of several hundred Chiaris, I've only seen a tight phylum in 1 or 2 cases. So, I will say my experience is very limited, and I am not. I know some will do the Chiari decompression. Then, if that doesn't improve, then they will cut the tight phylum. In my opinion, if there is a tight phylum, I would advocate to treat that first before we're doing the decompression surgery.
Yeah, I agree with you. But here in Brazil, we have some legal problems with this. Fortunately, I see some patients that went to other countries to do this kind of surgery. Of course, without a confirmation of tight phylum, it just a suspicion of Chiari, and then this surgery became kind of a miracle to treat Chiari. And we know you presented extremely well. Chiari and the other speakers presented some very interesting points. Chiari is a very how can I say? It's a very individual situation, and then you need to tailor almost selectively in terms of patients. So I think that I agree with you. Maybe I did 1 or 2 surgeries in real tight phylum, but not as some people advocated to treat this extremely complex disease. So thank you, George. Thank you, Nari, for this excellent presentation today about Chiari.
Thank you very much, Professor Ricardo Santos de Oliveira. Dr. Jallo, I have one question for you. You mentioned about asymptomatic patients with syrinx, and if I read your slide correctly, that your recommendation was for surgery. Am I right? And would you observe a few times before surgery? Would you look at to see whether if the patient is asymptomatic and if the syrinx was not enlarging, whether would you hold on? That's one question. And the second question is, if a patient with Chiari who's asymptomatic kid, what's your advice for playing any sort of sports, let alone contact sports? So 2 questions, thanks.
Naren, I think that's great questions. I'm going to take the second first. I don't have I don't put any restrictions on my straightforward Chiaris. Again, just Chiari, no basilar invagination, no other conditions. I don't place restrictions. If again, if they want to play sports, they can play sports. I may educate them about avoiding contact sports. But I can tell you I've had I had 2 or 3 high school football players with a Chiari, and their only symptom, no syrinx, Chiari, only symptom was headaches, classic Valsalva-induced headaches when they were in the weight room. I educated them. I said, you are asymptomatic. If you don't do sports, maybe you shouldn't do any heavy weightlifting. But they continued to play football and really saw no complications associated with it. And I would, 2 of the 3 actually had improvement of their Chiari as I followed them over time. The other question is the asymptomatic Chiari with syringomyelia. If it's truly a syringomyelia, not a dilated central canal, because that's a lot of my practice is really just a small dilated central canal, some cerebral ectopia, go see the neurosurgeon. But if they do have a syringomyelia and they're asymptomatic from their Chiari, I'd still advocate for surgery on those patients.
Thank you, Dr. Jallo. I think with controversies in Chiari, I think we can just have one whole day on one aspect of controversy. There are a few questions, Dr. Jallo, for want of a time. May I please ask you to have a look at them? I just want to acknowledge that we talked about bony decompression for Chiari. Certainly, the first paper on bony decompression for Chiari was from Professor Atul Goel in the 1990s. So Dr. Atul Goel has strings of first, and so it's important to acknowledge that. I'm just going to go to the next lecture. Thank you very much, Dr. Jallo. I think I will we'll give it another 6 months, and then we'll have just a whole day on controversies. And there's one question from Dr. Risk. Dr. Risk, do you have a question, Dr. Risk?
Just want to comment that there's some good articles out there to support the lack of restrictions of patients playing active sports and Chiari malformation. So it's not just, we feel this way. And, we don't restrict them from driving cars or being in a car because the risk is, of a high impact injury is higher. So, it's better to be active than sitting on a couch and not doing anything, especially at this child age and the rising obesity rates in the United States or in the Western world.
Thank you. Thank you, Dr. Risk. Before we go to Professor Brockmeyer's lecture, just for the reason of controversy, we have to have some sort of disagreement. Professor Brockmeyer, if it was a syrinx in an asymptomatic patient with Chiari, would your management be similar to Dr. Jallo, or would you follow up the child and only if you operate if it gets larger? Thank you.
It depends on the syrinx. A large cervicothoracic syrinx, like a holocord syrinx, I would probably recommend treatment, no matter what the symptoms are. Like a small syrinx that was shown that George had, I'd be inclined to probably follow that patient. In the back of my mind, we've all seen patients with ruptured syrinxes. Probably had several dozen of those over the years. Those can be extremely debilitating. I'm not saying that you want to decompress people for prophylactic treatment of that, but that's something that should be discussed with the patients. And somebody who presents with a sudden deficit in a ruptured syrinx, they're in trouble, over the long haul, as we all know.
Thank you. Thank you very much, Dr. Brockmeyer. Dr. Jallo, any comeback, Dr. Jallo?
No, I mean, I agree with Doug. I mean, I think it really depends upon the size of the syrinx and what we define as large. I don't do small syrinxes, but for me, a syrinx that's 3 levels, and that comprises up to 50% of the canal. I treat a syrinx almost like a tumor, right? There's a tumor, although asymptomatic, it's putting pressure on the spinal cord there. That's all.
Thank you. While we are still on the controversies, in terms of the long run, in any of these controversies, are we ever going to come to some sort of agreement on this? If you have the same meeting in 25 years, because there are so many multifactorial aspects of Chiari. Which one do you plug, and what's your thoughts on that, Dr. Jallo?
I think we're making progress. I mean, I think, there's been some consensus opinions, both in the United States as well as abroad, in terms of the management for Chiari's. Are we going to see one, treatment algorithm from all neurosurgeons? No, I think there's still going to be very individualized treatment depending upon training as well as the region of the world that you practice in.
That's great. Thank you very much. So it's an honor to introduce Dr. Douglas Brockmeyer. Anyone in Chiari, in pediatric neurosurgery in Chiari, knows Dr. Brockmeyer. Synonymous with Chiari, complex Chiari is my favorite book, is his book on pediatric Chiari malformations. So it's an honor to have Dr. Brockmeyer to give us a lecture on complex Chiari. Thank you, Dr. Brockmeyer.
Great, fantastic. Thanks for the introduction, Dr. Narintharan. I want to thank you for your invitation in general to speak on this topic. I'm going to add a little bit of controversy here. I know this conference has been going on for a couple of hours, and so I want to share some new thoughts and some new concepts. Plus, I want to share some preliminary results from a large registry that we've created in North America, and then some work that we've done locally at our hospital. So I just retired from pediatric neurosurgery after 33 years, and I'm half-time on the adult side. And what I'm going to try to do in this talk is just distill the information that I've gathered over that period of time and share it with you. So there we go. So first, I want to acknowledge my mentors. Ron Applebaum was at the University of Utah. He was very influential, incredible thinker, and incredible speaker, or incredible surgeon, I mean. And the second person is Dr. Menezes. And I think everybody in this webinar owes a debt to Dr. Menezes and his pioneering efforts back in the 80s and 90s, looking at this problem and tackling the problems of the craniocervical junction. So we're going to move to try to reimagine Chiari malformation. And this gentleman has been shown several times already today. We all know who he is. Hans Chiari, 1891, published his original paper. And then in 1896, described the Chiari 4. And then Julius Arnold got in the act in 1907 when his students recommended calling it the Arnold-Chiari malformation, which is a term that's rarely used. So at this stage, there's a trend towards subclassifications of the Chiari malformation. And obviously, everybody's familiar with the classic Chiari 1. There's a Chiari 0, a Chiari 0.5, a 1.5. We're part of the issue where we published our paper in 2012 about complex Chiari, describing it's a Chiari 1.5 with the obex down. and the clival cervical angle less than 125. And I think Hans Chiari would look at this. If you were dropped in from another planet at this point and you really stepped back and you tried to look at this, you'd probably conclude that this is really crazy. You know, that what is this subclassification scheme really adding to our understanding? And does it provide utility? Does it provide a coherent paradigm for further learning? Does it enhance our ability to do research or enhance education? And most of all, does it really improve patient care of which subclassification a patient lies in? Or does this classification represent something that's archaic, it's cumbersome, it's hard for lay public to understand? If you were a medical student and took a step back and tried to understand the difference between a Chiari 0.5 and 1.5 or whatever, would you really be able to understand that? And in my mind, is it generally obsolete? So this is brought to light with this example. So here's a patient, there's two patients who come in. On the left-hand side, I think everybody would agree, probably a Chiari 1. On the right-hand side, sort of a classic Chiari 1.5 with a low obex down here, very, very tight at the foramen magnum. And you look at this, which patient was symptomatic and underwent surgical decompression? And I don't know what everybody would say. We'd probably have a 50-50 split. I'd probably look at the one on the right and say, wow, that patient needs surgery. But that patient came in completely asymptomatic, and the patient on the left underwent surgery. So how do we make sense of this? Are we at risk of classification and measurement fatigue? And maybe we should be placing less focus on eponyms and classifications and more effort on developing a useful pathophysiologically driven nomenclature. So this is where some of the controversial part kicks in, So I got together with my colleagues, Dave Limbrick, who spoke earlier, Cormac Marr, Jerry Grant, all distinguished surgeons and thinkers in the Chiari space. And we published this article in this last year about primary rhomboencephalopathy that I'd like to share with you in this audience because I think it's important to understand. So the rhomboencephalon obviously is defined as the hindbrain, and it consists of the pons, the cerebellum, the medulla, and the intervening structures, the fourth ventricle. And if you have a disorder of the rhomboencephalon, which is what we're talking about here, by our logical way of thinking, you should call it a rhomboencephalopathy. And I think that makes perfect sense. We defined primary rhomboencephalopathies as the classic Chiari findings, the congenital Chiari, including all of the subclassifications that I just mentioned, and secondary rhomboencephalopathies, including all the other causes of tonsillar ectopia, including spina bifida, spontaneous intracranial hypotension, the IIH, craniosynostosis, which we just talked about, and Chiari 3 and Chiari 4. So two separate things that should be thought about separately because they have different pathophysiologies. So there are three fundamental mechanisms underlying primary rhomboencephalopathy, and it's three and only three reasons to perform surgery. One is a hydrodynamic problem, which we're going to talk about here in a second. The second one is neural compression, and the third one is biomechanical issues. And each one of these pathophysiologies has a cause or a driver. It may or may not have a genetic cause. It has certain signs and symptoms, surgical indication, and goals of treatment. We're going to go over these. As far as complex Chiari goes, as people know, with complex craniocervical kyphosis and severe constriction, all three of these pathophysiological mechanisms can coexist in the same patient. But having said that, most patients have one particular cause and driver that's driving what's going on with them. So for hydrodynamic mechanism, the cause is exaggerated pulsatility and pathological CSF flow. in the cervicomedullary region, and you can have microstructural channel abnormalities either in the brainstem or the cerebellum. It doesn't have a genetic cause, but the symptoms that we all know are Valsalva-induced headache symptoms that we see over and over and over again, and syringomyelia is a hydrodynamic problem. The indications, again, are a syrinx or Valsalva-induced symptoms, and the goal of surgery is to restore normal CSF flow. Neural compression is just plain and simple crowding and bony compression and tissue distortion, primarily of the brainstem. It's possible that chromodomain genes may be responsible for some of this in young children. What are the signs and symptoms? So we all see patients, younger than 4 typically, with oropharyngeal apraxia, and they have swallowing difficulties, sleep apnea, motor delays, speech delay, which we haven't talked too much about in this conference. And that's a brainstem compression symptom. Or an adult patient comes in with a bulbar myelopathy and no Valsalva type symptoms, and that's just pure brainstem compression. And so the indications include oropharyngeal apraxia or a sensory or motor disturbance. And the treatment goal here is fairly straightforward. It's just decompressing the neural structures to provide more space. The biomechanical mechanism is more complex. It involves the cause, obviously, is craniocervical dysmorphology, perhaps ligamentous dysfunction. We're going to talk about HOX genes as a possible cause of that, and we had a paper published about a HOXC4 genetic mutation as a predisposition. The imaging findings are craniocervical kyphosis with or without basilar invagination, pain syndromes, headache and neck pain, or bulbar myelopathy. Indications include severe craniocervical kyphosis with brainstem compression. It can also occur with iatrogenic craniocervical instability, patients who've undergone multiple Chiari decompression procedures. Some patients have come to me with 2 or 3 previous surgeries and iatrogenic instability, or whether the patient has hypermobile EDS. And the goal with this patient population is to stabilize the craniocervical junction or decompress. So I'll just briefly mention this. We published a paper a couple of years ago with a couple of family trees. We had 2 sisters present to us, both with HOXC4 mutations and severe craniocervical kyphosis and syringomyelia, which needed decompression, fusion, and odontoid reductions, and another large family that was tracked through with HOXC4 mutations. So these these patients are fairly rare, but they're out there, and it's something to be aware of as a possible cause for this severe syndrome of craniocervical kyphosis and craniocervical dysmorphology. So I typically am not a big fan of treatment algorithms, but in this setting, I think it's relatively helpful to break this down. So the biomechanical group, there's a toolbox that you have available for you. And that includes the suboccipital decompression with or without duroplasty, and some sort of cerebellar tonsillar reduction, if you choose to do that, whether it's a coagulation or a resection. Occipital cervical fusion with or without odontoid reduction, and we're going to talk about that here in a few minutes. And then also ventral brainstem decompression or odontoid resection is part of the toolbox as well. For hydrodynamic patients, if you have a syrinx, obviously most people are going to do decompression and a duroplasty with or without manipulation of the tonsils. If it resolves, then you're going to follow the patient. If it doesn't resolve, if the syrinx doesn't go away over time on the serial imaging, in my experience, it's probably 5 to 10% of the patients, even despite a reasonably thorough, perhaps aggressive decompression. I think a lot of people on the second go round, and we're going to talk about reoperation, are going toward fourth ventricular stents from the fourth ventricle to cervical subarachnoid space. And I think that's been very effective in a lot of patients. And if that doesn't work, then you're thinking about the biomechanical pathway. For patients with the Valsalva-induced symptoms, It's very, very similar algorithm. And then with the neural compression, basically the idea is just to decompress the area and create more space. So what bony metrics do we use to determine abnormal biomechanics? And I'm not going to talk so much about instability in pediatric Chiari because that's actually quite uncommon. But we all know about the PBC2 measurement, the perpendicular distance between the basion and the posterior inferior aspect of C2 was dichotomized greater or less than 9 millimeters. The pro of that measurement is that it's very easy to measure and most everybody's familiar with it. The problem with the measurement is that's an indirect measurement of what's going on at the craniocervical junction. And really the odontoid and the retroflexed odontoid is just along for the ride. What's really driving that is the position of the occipital condyle and its relationship to C1. And that relationship and that growth is all genetically driven during embryogenesis and early childhood. Or whether you should measure the bony PBC2 or soft tissue. And the problem is it's not very sensitive or specific when it's been looked at in large patient series. The clival cervical angle of less than 125, we described that back in 2012. It's easy to measure. It directly assesses the relationship. The problem is it's not very sensitive. And if you have a clival cervical angle less than 125, it doesn't necessarily mean you have instability or craniocervical, abnormal craniocervical motion and you need surgery. However, if it's greater than 125, the chance of needing any type of craniocervical fixation is very, very low. A more direct measurement is one that we developed at the University of Utah. This condylar C2 SVA looks at the relationship of the midpoint of the occipital condyle and the relationship of the bottom of C2 and how that kyphotic relationship is at the area where the load is being transmitted through the skull into the upper cervical spine. It's a direct measurement. It is sensitive and specific. And I'll refer you to this paper here, this multi-center validation of that measurement using the Park-Reeves database. Problem is it's a little more difficult to measure, and I'm not going to go into the details of that, but it's a worthwhile concept to be aware of. And again, basilar invagination is easy to measure, but there's very few studies really looking at the sensitivity and specificity of what that actually means. So ultimately, we don't understand much about how the craniocervical bony morphology can drive symptoms or cause progressive instability. So here's a patient who came to me with severe craniocervical kyphosis on the left-hand side, retroflexed odontoid. When you look directly at the occiput C1 joint, and I'm not talking about C1, C2 that Dr. Goel has talked about over the years, but this relationship here. So here it is on the MRI, here it is on the CT. And what does this mean? Do the capsular ligaments and occiput C1, are they intact? Are they not? If you do a posterior decompression, are you going to unmask instability? And these are questions that we just don't understand at this point. So what about the ligaments? We talked about hypermobile EDS. It's fairly common in adults, especially young adult females. It's uncommon in children less than 14 years of age. It's very poorly studied in the pediatric age group. I prefer not to use the term instability because it implies that cranial fixation, occipital-cervical stabilization is necessary then. I like to call it abnormal craniocervical motion, whether it's at occiput C1 or C1, C2. We're going to talk about that in a second. Again, we talked about iatrogenic craniocervical pain syndromes. That can be ligamentous in origin. Patients come in with severe de novo craniocervical kyphosis. They have a couple of surgeries for a variety of reasons. Those patients can come in extremely disabled with lots of head and neck pain. My preferred treatment for those patients is to go directly with a collar trial, a hard cervical collar. Sometimes the improvement can be dramatic and very durable in the collar. And you have a very, very careful conversation with the parents or the patient about whether that craniocervical fusion is necessary. Dynamic CT is something I've been doing a lot in my adult practice these days, and also with older teenage patients. Flexion and extension and rotation CTs. If you have greater than 41 degrees, this is all well published in the literature, greater than 41 degrees rotation at C1, C2, or 80% loss of facet overlap at C1, C2. It's an indication of potential instability in patients with hypermobile EDS, and patients can benefit from surgery. You really want to do the fusions only as a last resort. It's a very, very big decision for patients, and you want to be very careful with this. However, having said that, the results are frequently life-changing and dramatic for the patients. I'm going to shift gears here for a couple of minutes, and I want to share with you preliminary analysis of a registry that we've been running in North America called the Chiari Surgical Success Score. And it's the first multi-center prospective patient-reported outcome-driven study regarding Chiari malformation. And the primary aim of the study is to determine the probability that certain clinical or radiographic variables will predict a favorable response to surgery. And it's defined by two simple outcome questions. The first is the success of the surgery based on a 5-point Likert score, and you have to have a 4 or a 5 to define success. Plus, you need to have a 4 or a 5 on a question of whether the patient or the parents would recommend or would agree to surgery again. So that's our primary outcome of this registry. The secondary outcomes is looking at the pre and post-operative changes in the patient-reported outcome scores. We use PROMIS 29 for adults and PROMIS 25 in kids. And we use the Migraine Disability Assessment Score, the MIDAS scores, to look at the headache burden for these patients. So these are the centers that have been involved. There's, on the left-hand side, the table shows the pediatric enrollment, and you can see there's a number of centers, approximately a dozen centers across the country, and actually including one in Australia. Over 1,200 patients screened and 217 pediatric patients enrolled. We're awaiting our final numbers of the patients being followed for 12 months. The enrollment, the adult side has been slower, and you can see that on the right-hand image, 771 screened, 195 enrolled, and 51 with a 12-month outcome. So here's the good news, and this is what I wanted to share this with everybody. Again, this is preliminary data, but I think this is very powerful. These are the pediatric patients. This is as of July of 2025. 92 pediatric have completed their 12-month follow-up. 81% improved or complete improvement, so that's a 4 or a 5 on the Likert scale. 83% of the parents agreed that they would undergo the surgical procedure again. And it has to have, for a surgical success, you have to have a 4 or 5 for both of those outcome measures. So it's a high degree for this. That's a very stringent definition of success, but it's a very, very high rate of success in this patient population. What was really interesting are the secondary measures, and you can see that the MIDAS scores improving to a significant fashion. Headaches, physical mobility, anxiety, fatigue, pain interference, and overall pain on the PROMIS scores. This is 1 year patient-reported or parent-reported outcome results. So this is very, very powerful, I think. And so we're comparing surgery versus non-surgery, but I think this is the first study to really show this in more lifestyle or symptom burden outcome measures. So with the adults, we have less patients who've completed their 12-month follow. So this is very preliminary. and it's the same story: high degree of surgical success and high degrees of changes in the preoperative versus postoperative symptom burden measured by the PROMIS scores and the MIDAS scores. So we have to complete 300 patients in order to build a robust surgical success score, 300 on the pediatric side, 300 on the adult side. There'll be two separate journal publications when they come out. So this is an interesting project that we completed at University of Utah. And over the years, I've been really obsessed with avoiding reoperation in patients. And we all know Dr. Jallo and others have talked about reoperation rates with bone-only decompression and whatnot. And so I've taken this to heart, and I've looked at my own experience over time, and we looked at this with our fellow from 2 years ago, Dr. Aaron Yango Khan. So what we did is that we looked at 12 years of data from our institution, 1,400 craniocervical procedures with a preliminary EMR review that cut us down to 451. And we did a post-EMR retraction. We were left with 272 patients, first-time Chiari patients treated at our institution over 12 years. So that was our patient population. And we used this statistical technique that I wasn't familiar with before, and I'm not an expert in it. It's called a CHADE analysis. Maybe some of you have heard of it. Chi-square automatic interaction detection. And it's a non-parametric method aimed at identifying how well a continuous or categorical independent variable predicts the desired outcome. Our outcomes were the need for a second Chiari operation or Chiari directed operation, which would include a repeat posterior fossa decompression, placement of a fourth ventricle stent, a craniocervical fusion, or an odontoid resection. So that was the reason for those were our outcome, our primary outcomes. And we looked at the preoperative list of signs and symptoms that the patient had and a number of radiological variables that we discussed earlier in the talk. And it turns out that the variable that predicts the need for a second operation, the number one is the degree of foramen magnum crowding. That if the posterior fossa and the cervicomedullary CSF spaces were obliterated, there was a significantly higher chance of needing a secondary operation. And this, in my mind, this falls into the category of all this hydrodynamic discussion that we've had today and trying to understand the impact that this has. The next most powerful, if you took those patients who had obliterated CSF spaces, the next most powerful predictor of redo operation was the presence of a syrinx. Most of those patients either went a placement of a fourth ventricle stent or a syrinx shunt. And if you had a syrinx, the next most powerful predictor of repeat operation was, in this case, the PVC2 distance or the extent of ventral brainstem decompression. And these are the patients, these are the complex Chiari patients. And it's a smaller number of patients, obviously, here. So you had greater than 8.2 millimeters PVC2 distance. You can see a total of 21 patients underwent craniocervical fusion in this complex group of patients from 272 starters. So when we interpreted these results, we felt that this CHADE analysis identifies 4 clinical radiographic phenotypes at risk for Chiari-related reoperation. And the first is just the classic Chiari operation, and the chance of needing a reoperation is very, very low. If you had tonsil herniation, if you had crowding or open CSF spaces but not obliteration, the chance of reoperation is very low, probably less than 2%, usually one and done type of surgeries. For obliterated CSF spaces, that's the next sort of clinical radiographic phenotype that this identifies. Obliterated CSF spaces in syringomyelia is the next group. And then the last group is the obliterated CSF spaces, syrinx, and ventral brainstem compression. And this is the complex Chiari population that we've been discussing. So surgical adjuncts and techniques, what do you do with these patients? So a lot of these patients, if you had severe basilar invagination, you can reduce that at the time of surgery. You can also use preoperative halogravity traction. This is an example in a patient with osteogenesis imperfecta, but it's a good example of showing how powerful this technique is and how much reduction you can get. So here's our patient in the halogravity traction, which is very, very effective. And then ultimately his ultimate outcome, and you can see the position of the odontoid after this technique. And this is not an old, this is not an 2020. So for patients who do require fusion, this is what I do in my hands. If they need an occipital C2 fixation, I don't go lower than C2. I place C2 PAR screws bilaterally. I use a rod plate construct. Most of these patients need odontoid reduction. In just a minute, we're going to talk about how that's done exactly. I use rib grafts that span from the occiput down to the posterior arch of C2. This has been shown in a combined orthopedic neurosurgical publication to have higher rates of craniocervical fusion compared to other techniques. I use recombinant human BMP at the contact points at the top of the rib and the bottom of the rib. I put the gel foam pledgets there. I put a screw through the rib into the occiput to create pressure on it. And that aids in fusion, I think, just with the stress on the bone. And Wolff's Law, you get higher rates of fusion. And I use a cable around the rib and around the rod to compress the rib to put stress on it. And there's no need to fixate C1. So one thing that hasn't been talked too much about is how do you do an intraoperative odontoid reduction? And many times you can get up to a half a centimeter or a centimeter of improvement. This is my stepwise way of doing it. You insert the C2 PAR screws. You cut and bend the occipital cervical rod plate that we just talked about. You place the occipital screws into the plate portion up above. The rod portion hangs down below and is loosely held into that C2 tulip with the lock nuts loose. So the top is tight, the bottom is loose. I break scrub, I go to the head of the table, and then I put I do a manual reduction with the first movement is just axial distraction, and the second movement is extension. What that does is forces the rods ventrally, and that pushes the C2 body, ergo the odontoid ventrally away from the brainstem. And when you're happy with that, you lock the C2 screws in, get an O-arm spin to confirm your reduction and see how that looks. Other issues include using the postoperative cervical collar. We have a great orthotist at our place, and he makes nice collars that are comfortable for the kids. And then this is my imaging protocol for documenting the fusion. I get an x-ray. We could go all day about this topic in and of itself. I get an x-ray at a month and 2 months. The 3-month visit I skip. At 4 months, I get a cervical CT scan. And I think that has a high yield of capturing the successful fusion with the lowest risk of CT radiation. For odontoid resections, we published a paper in 2021 going over this. I'm not going to spend too much time. We use this protocolized approach with our ENT colleagues. It's an endoscopic transnasal, transoral odontoid resection, and it's become very, very straightforward for us. And basically, it amounts to on the impact on the patient of just having an adenoidectomy, and the patients are discharged shortly after surgery. So here's a few case examples I'll go through. So here's an example of this hydrodynamic issue. A 14-year-old girl with severe Valsalva headaches, complete obliteration at the craniocervical junction, the CSF spaces, some a little bit of craniocervical kyphosis. Here's the list of potential procedures. A bony decompression, you can do a duroplasty with tonsillar coagulation or tonsillar resection. For her, we decided to do a tonsillar resection, and here's her post-operative imaging on the right-hand side, and she had nice improvement symptomatically. Here's a 10-year-old boy with syringomyelia. These are pictures that we all see all the time. 28-degree scoliosis. Again, the same treatment algorithm, but I think the literature is showing that some sort of a duroplasty technique with or without manipulation of the tonsils is superior to just bony decompression. If the syrinx is still there after 6 to 12 months, re-exploration of the decompression or placement of a stent is a reasonable way to do it. And again, this is not a new concept. This is published by Dr. Scott previously, showing what the stent placement results in. So here's a type of patient which is fairly common. So here's a 2-year-old girl with severe oropharyngeal apraxia. She's just got straightforward brainstem compression, neural compression. And so you're going to address it accordingly. Again, some people would do a bony decompression with or without opening the dura. With this type of patient, I think being relatively aggressive in doing a tonsillar resection is probably, in my hands, the best way of handling that patient. This is a patient who came to me with severe bulbar myelopathy and axis assimilation, retroflexed odontoid. This would be the classic, complex Chiari malformation. It's clival cervical angle 110, CC2 SVA of 12 millimeters. This patient was in trouble. So you're going to handle this in a staged fashion. This patient needs Chiari decompression. He needs his brainstem decompressed, and he needs to be fixated over time. He needs a fusion. So we performed the suboccipital decompression, duroplasty with tonsillar resection. We did an in situ OC2 fusion. There's no way you can reduce the odontoid because C1 is fixed to the clivus and you can't push it forward. So you have to do in situ fusion. And then for the residual odontoid compression, we did our endoscopic transnasal, transoral odontoid resection. Here's another patient with Valsalva headaches, came in severe Chiari, severe craniocervical kyphosis. And we all see these patients over time. And again, you can do the duroplasty with tonsillar coagulation. That's what I did up front. So this was back in 2018, over 7 years ago. He came back about 4 months after surgery. And I'll be honest with you, I have to take a step back because my thinking has evolved. He came back with severe headaches and neck pain. And it was hard to determine whether this was a biomechanical problem or whether it was just a CSF flow problem or hydrodynamic problem that was driving his symptoms. I put him into a hard cervical collar, and he had significant improvement of his symptoms. So we decided to do a suboccipital decompression duroplasty. I did a tonsillar resection on this patient secondarily, and I think we all could agree that there are patients that come in with severe crowding. They can be very, very difficult to manage with just the standard decompression techniques, and they can come back with recurrent or continuing symptoms. And then I performed a fusion with odontoid reduction on this patient, and this is the overall result. So in summary, I'll just give you a brief overview of my approach that's evolved over time with 33 years of practice. Obviously, this Chiari malformation, rhomboencephalopathy, whatever we want to call it, it's a spectrum of disease and it's multifactorial. It's very complex, and that's why we're so interested in it, and that's why we love it so much. Identifying the primary problem, what you're trying to fix. Is it a hydrodynamic problem, a compression problem, or biomechanical problem? Really clarifies your thinking. Patients who fail to respond to simple decompression often have complex craniocervical abnormalities or intradural pathology. Some of those patients have syrinxes or ventral compression. I've done a lot of intradural work that not many people talk about the contribution, for example, of the tonsillar branches of pica that can come up either unilaterally or bilaterally and form obstruction to CSF flow at the foramen of Magendie and the obex, and what role those things happen, or what role those things have. And so sometimes there's intradural pathology that's more complex that needs to be addressed. That's my point. And certain risk factors allow early identification and improved management of complex patients, including this concept of the obliteration of the space in our craniocervical measurements. So what does the future hold with research? We need registries. We need this severity score. It would be very, very helpful. Better understanding of the craniocervical bony morphology and function, and the understanding of ligamentous hypermobility and what that contributes. Advanced CSF flow modeling. I know Dr. Limbrick and others have talked about that. Cerebellar resting state networks. Educating PCPs about Chiari or rhomboencephalopathy and its effects. And what about AI? People talked about what happens 20 years from now or 10 years from now if we had this conversation in the future, this conference, and it's all going to be dominated by AI and machine learning. And I think that creating these classification schemes in this organizational framework is going to be very helpful. So it becomes a supervised learning approach with machine learning, with these classifications, building the framework around which the AI and the machine learning would function. So I want to thank everybody for your attention, and I'm happy to answer any questions that you have. Thank you.
Thank you very much, Professor Brockmeyer, for that excellent lecture. Giving us we have certainly in my practice, when I did Chiari, it was once or twice we get these complex ones. Even the simple ones are difficult, but it's really good to hear from you how you manage these complex cases. And as you said, AI is going for something as complex and multifactorial. Probably AI is going to be a very powerful tool. I think that's for the craniocervical junction community to see how to bring that on. Before I move to our distinguished faculty to ask you questions, just to remind, at the end of the housekeeping, at the end of the next talk, next lecture from Dr. Rizk, I'll put the link for the feedback form. It's a very simple feedback form. It's an open paragraph for you to give your feedback. There's no mind-numbing radio button to click. And then I will send you a certificate for attendance, and as well as a database for Chiari that will run on Mac or Windows. You have to just download the free LibreOffice, and also a software for pediatric calculations which will run on Mac or Windows, and also the web link for the Chiari, Chicago Chiari outcome scale. So it's a real honor to have two more distinguished panelists. First of all, Dr. Sushil Patkar. He's from Pune, very experienced spinal surgeon, and particular interest in craniocervical junction, spinal neurosurgeon with particular interest in craniocervical junction. And we have got Dr. Sama El-Baba, whom we all know from the pediatric side. Dr. Sushil Patkar, your comments and questions to Dr. Brockmeyer, please. Thank you, sir.
Yeah, Professor Douglas, was a fantastic talk and very, very informative. I have two questions for him. Number one is how much importance do you give to the occipito-atlantal angle between both the occipito-atlantal joints? Because more than 130 means there's a hypoplasia of the condyles, and this patient is going to go into instability after surgery. And second, the technique which you showed of putting the rib grafts was somewhat similar to that which has been pushed by Dr. Sarat Chandra, where he talks about DCR, that is distraction, extension, compression, reduction. And to correct retroverted odontoid, it is important to push something into the atlantoaxial joint, and the fusion has to occur across the atlantoaxial joint. What are your comments on both these questions?
Yeah, I'll take the second one first. So, the DECRA procedure, I think that's what you're describing. And I think that's for patients specifically with atlantoaxial subluxation, I think that's very effective. I know Dr. Goel was on the talk. I don't know if he's still on the talk. And he has a large experience with that technique. I don't use that specifically. I think that you asked about the clival cervical angle. I'm not treating the number. And I don't think there's one number. There's patients that are at higher risk, and you're going to pay attention to those patients. But it's not like, oh, you come in with 110 CXA, and we're going to fix you. We're going to put you at 130 or 135. That's not what the goal is, I don't think. In a lot of patients with severe kyphosis, you can do a posterior decompression. They do just fine. And I think that's the integrity of the capsular ligaments, at OC1 and C1, C2. If they're intact, most kids will not become unstable over time. But I think that, again, repeated surgeries over time can weaken that tension band in the back. And I think just the weight of the head over time, you have that glacial instability and further kyphosis. We've all seen it, and I think that we need to treat those patients accordingly. It's not super common, but when you have a patient come in post-operatively who's really disabled with headaches, neck pain, can't go to school, can't do anything, and that's really it's a difficult decision, but it's definitely the right management, I think, over time.
So am I right that you don't advocate a primary fusion procedure? You would first do the decompression and then decide with the new, if there is any problem, then decide for a fusion. You wouldn't go for a fusion straight away in any patient.
Yeah, well, it depends. So it's like that last patient I saw came in with severe brainstem symptoms, and he needs everything. Right? He's going to need a posterior decompression, fusion, and odontoid resection to decompress his brainstem and manage him over the long haul. So sometimes there's a multi-stage procedure that has to happen for certain patients. Those patients are uncommon. But the typical patient who comes in with like a CXA of 115 and they're tight, I think the consensus, and they have Valsalva-induced headaches, again, doing a standard decompression, seeing what happens over time. If they fall apart over time and they develop kyphosis and pain, then going back to do a secondary fusion is a pretty rational way to manage that. Like I use fusion as a last resort. They have to prove they need the fusion. Let's put it that way.
Thank you. Thank you.
Thank you very much, Dr. Patka. Was the first question answered, Dr. Patka? Sorry,
No, I don't know. The question was the clivo, the occipito-atlantal angle, and like he said that these figures are not important, and he would rather go with the clinical situation rather than these figures in the what kind of clivo-axial angle or atlantoaxial angle.
That's great. Thank you. So both answered. Dr. Samar El-Baba. Dr. Samar El-Baba is from Orlando in Florida, from Arnold Palmer Children's Hospital. He's the head of the department there, as well as the chief physician, Dr. El-Baba. Your questions and comments, Dr. Brockmeyer. Thank you.
Thank you, Narayan, and thanks to all the faculty and colleagues attending today. And as always, excellent lecture by Professor Brockmeyer, very enlightening, and I learned so much. One of the main things I learned from your talk is your focus on the clinical symptoms and how patients, radiographically, they may look good, and then they come back and they have symptoms. You put them in a collar, and now after the collar, you started thinking in a different direction. towards a successful treatment plan. How about patients who come, like let's say with a Chiari type 1, a syrinx? Very soon we're not going to be saying Chiari type 1 with this thromboencephalopathy. Actually, probably it's the future where we're heading in understanding this disease. But let's say a patient comes with a Chiari type 1 and a syrinx, and we do decompression like most of us do. Syrinx gets better, clinically better. A year later, they come to the office, they look amazing, but now the syrinx is slowly coming back. And those are the kids, especially kids under the age of 10 who I struggle with. And I would like to learn from you and listen to your algorithm. How do you differentiate between clinical and radiographic progression, and do they need to match to change the treatment plan or not? Thank you.
Yeah, Summer, thank you. So that's a great question and something that I've struggled with. Again, the rhomboencephalopathy concept, I haven't talked a lot about it over the years because it's new, and I wanted to introduce it to this sort of distinguished international group today, just to sort of bring it to people's attention. Those delayed recurrent syrinx patients, what my mind immediately goes to is there scarring at the fourth ventricular outflow? Okay, so that, and there's a variety of reasons for that, right? You know, the amount of blood that was in if you did an intradural procedure, how much blood was in the intradural space, how much tonsillar manipulation did you do? Was there a web? Was there a blockage from the tonsillar branches of pica? You know, those are just four things that come to mind. And if it's clearly getting worse over time, and I'm sure that if left untreated, it's going to continue, I'll re-explore it. And if there's evidence of scarring, and I can open it up and I can confidently say the chance of that re-scarring is very low, there's not a lot of scar, I'll leave it alone. I won't put anything in. If there's a lot of scarring that you have to take down, I'll definitely put a stent into those patients. And I think that most people are going in that direction. A lot of people are. And that works like crazy. And there's a building experience with that. And if you have that outflow obstruction and it's scarred, that's just what's going to happen.
Thank you, sir.
Thank you very much, Doctor. Thank you very much, Dr. Elbaba. Dr. Patkar, do you have any more questions?
Yeah, one more question for Professor and everybody. When you do a posterior fossa decompression and open the dura, there are some who advocate not to open the dura and just leave the arachnoid, and some would say you must open the dura and the arachnoid and open the fourth ventricle. What is your opinion about making an attempt every time to open the fourth ventricle and the foramen magnum?
My reply to that is that if somebody has a hydrodynamic problem, it's my responsibility to make sure that the outflow obstruction is addressed. So I will explore the fourth ventricle. If the obex is low lying and the tonsils are low lying, and this is my thinking has evolved over time. And I hopefully it won't be too controversial here, but I've gone more toward tonsillar resection more than tonsillar coagulation because that creates a lot of inflammation. And whereas a subpial resection has less inflammation, I think you're removing tissue, but ultimately less external signs of trauma and less chance of having scarring that's going to cause more trouble down the road. So I've been going more toward tonsillar resection over time and making sure that the CSF flow pathway is open. That's just been my preference. And I've had a lot of success with that over the years.
Thank you. Thank you.
Thank you, Dr. Bhatkar. Dr. Samer Elbaba, any additional questions?
I'm interested in the comment from George earlier after his excellent talk, saying that he does not routinely perform neurophysiological monitoring for Chiari decompressions, which is obviously we all have different practices, different medical legal environments. Question to the distinguished faculty. Do we have enough scientific data now in the literature where one day we can come out with maybe guidelines or recommendations? This is a Chiari we should monitor, and this one we should not. A question to both all professors, all distinguished faculty.
Dr. Brockmeyer, do you want to first go?
Sure, I'll tackle that. I had a patient probably 10 years ago with severe kyphosis and really, really tight. I put her in the usual position and she woke up with a stroke, pica stroke. And I think that the odontoid was right at the vertebral basilar junction there. And that was enough for me. And that was a horrible experience. And so everybody with a tight posterior fossa or a craniocervical kyphosis, I'll definitely monitor those patients. Somebody with a routine Chiari that's wide open, I might not. So mine is situation specific, but I think if you're tight and kyphotic, you should be monitored.
Thank you. How about George? How do you decide to monitor or not?
Sam, a great question. I think in most of the cases, I don't routinely monitor, but I agree with Doug. I mean, I think it's a case by case, right? As an example, why do I don't monitor my routine Chiaris, but I monitor all my achondroplasia children, babies that need a decompression? And it's for that reason. I think we probably do need guidelines, but right now it's individual based, and it's ones, I would say the complex Chiaris are the ones I would consider it at this time.
How about a simple Chiari with a C-rings?
No.
Okay, thank you. Elias?
Sam, I'm happy to share with you a couple of articles regarding this topic, but there's really no, in straightforward Chiaris, there's really no cost benefits or any cases in the medical legal literature that's referred neuromonitoring as malpractice or substandard in a treatment of straightforward Chiari. So if these are cases that are selected based on the surgeon's judgment, that's fine. But there's a couple of articles out right now that don't show an added benefit of doing neuromonitoring in straightforward Chiari malformations.
And Elias, I agree with you 100%. I'll put those two articles in the chat for everybody.
Dr. Patrick, with your extensive practice, you must have seen enough cases or heard enough cases with patient post-operatively having problem after.
I do neuromonitoring the moment, like what Douglas said, that if there is a retrovertebral odontoid and severe compression, or I have established instability preoperatively, I would definitely go in for doing neuromonitoring during surgery. Sometimes in instability, just giving a prone position can change the potentials. So it is better to be safe than to be sorry, I would feel.
Thank you.
When I was a resident in south of England, in somewhere further up north, once again, the same as Dr. Brockmeyer said, I don't know the exact details of the case, but post-operatively had a stroke. So as I said, you are distinguished and incredibly experienced, but I'm always a bit anxious putting patients with Chiari in a good tuck position. Ideally, I would also like to have neuromonitoring to be safe. And sorry if I had the facility. Dr. Brockmeyer.
I just want to make one comment. So the monitoring's not perfect though, right? So once monitoring changed, the event has probably already happened.
100%.
You can undo the position and treat it and all sort. But the bad problem may have already happened, but there's always a delay in detecting it. So it's not perfect for sure.
And I've had cases where neuromonitoring was added on as a separate charge to the patients, irrespective of their insurance coverage. And the families get like a bill separate from the neuromonitoring company, and they phone in and say, not in all the cases, but they're starting to charge separately for services that insurances are not covering. I don't know if any of the faculty here has had that experience.
I think, yes, it depends if the neuromonitoring team is employed by the hospital or contracted company.
Yeah.
Thank
you. Thank you. In terms of Dr. Jallo, do you have questions for Dr. Brockmeyer?
Yeah, hey, Doug, I mean, great talk. When you stage your, posterior decompression and then your anterior odontectomy, what's the time that you typically wait before you perform the operations?
Yeah, that's a great question. So sometimes patients would come and they clearly needed everything. So tried it every way possible, where you do it all in one day, do it from the front, do it from the back, front. So basically what I settled on over the years was to do everything possible from the back, with or without the reduction. And then I'd probably wait, and then I'd get imaging afterwards, and then wait 2 or 3 days. And then I'd go from the front and do the odontoid, which is less morbid than people believe. And those patients recover within a couple of days with the endoscopic procedure. So I would stage that usually with 2 or 3 days in between.
Thank you.
Dr. Brockmeyer, if I missed, if you had made the point, if I missed, I apologize. When you are running the webinar, you have to do a few things. So in terms of patients with Chiari, do you routinely do flexion extension X-rays on them to look at the stability or not?
I do not. I do not.
Thanks.
I think the incidence of true instability in the pediatric population is very low.
Thanks. Dr. Patkar, I saw the guidelines, the WFNS published on that, and
Yes.
also said the same thing. Is that right?
Yes, you're right. But I think, you see, we do not have so much insurance and financial problems back here in India, and we can get the investigations done very easily. I also like to do when I do the MRI, I do the dynamic MRI. So that gives me an indication, and when the same MRI is being done, a dynamic MRI solves my problem, and I come to know if there's an instability there and then. I don't have to do a separate investigation.
Okay, explain what a dynamic MRI, please, Dr. Patkar.
We tell the radiologist, and they have a flexion extension while doing the MRI itself.
Okay, that's great. Thanks. Thank you. Dr. Elias Risk, do you have questions for Dr. Brockmeyer? While he's here, we better ask as many questions as him.
No, that was superb and masterful as usually, and 33 years of experience. I'm sure lots of families are thankful for your dedication, hard work, and also we're all thankful for all the work that you've done in pediatric neurosurgery, especially in Chiari.
Elias, thank you very much for those comments. I appreciate that.
Dr. Brockmeyer, I've got two general questions. One is from the chat box, and one is from me. I think I'll go to mine first. In terms of we through this conference symposium, we have said that Chiari is kind of multifactorial, important to work out, what kind of, as you said, whether it's hydrodynamic stability, what's the cause, and the complications that I have, the problems I have seen is that people usually, have a knee jerk that they see a Chiari, they go for a foramen magnum decompression. And in terms of working up, how long and how extensive should the workout be? I know it depends on how complex the case looks, but even for a standard Chiari 1 malformation, we talked earlier about cranial synostosis, we talked about genetics, we talked about instability, we talked about connective tissue disease, we talked about tethered cord, and how much thorough workup. Usually the neurologists are the ones who you expect to do thorough workup, but neurosurgeons are more keen on the operation. What's your thoughts on that? Thanks.
Yeah, great question. I think in the pediatric population, it's more straightforward. And I would do a complete craniospinal MRI as a baseline just to make sure that there's no other pathology that's driving anything. And after that, and if I'm comfortable with my decision making and how the patient presents, I'll just move forward. With adults, I'm learning it's a lot more complex. I've been doing this for probably 5 or 10 years. and trying to sort. It's very, very, very challenging. You know, IIH and hypermobile patients, et cetera. So there's a lot more hand wringing, and there's a lot more collaboration with headache neurology and dysautonomia and, you know, all these things. So I'm not really answering your question that very well, but it just is suffice to say on the adult population, it's a lot more complex.
That's great. Thank you very much. The final question is from one of the participants is that have you come across a family where the patient is asymptomatic, but it's Chiari, patients have gone through the internet and they are insisting that they want an operation, otherwise they are very, they have got so much anxiety. How would you deal with that? Thanks.
There's a lot of experience in this symposium. Maybe I would have a tendency just to say wait and see. You know, you could ultimately say somebody's going to do that operation somewhere, so why not me? But I tend to pass on those patients if they're driving the decision, if they're asymptomatic. I don't like treat the MRIs, and even if the anxiety level is high.
When you say pass on the patients, what does that mean, Dr. Brockmeyer?
I just say, hey, look, I can't help you. I can refer you to other people. I think that would be reasonable, but I'm not super aggressive in that scenario.
That's brilliant. Thank you so much, Dr. Brockmeyer, for that masterclass lecture, and we are all very grateful for your service to this field, and not only for our lecture, but to this field. Thank you very much, sir.
Thank you, Naren.
So we come to the important part we often don't do so well, is to systematically look at the outcomes in most of our practices. Certainly when it's a research, the outcomes are very carefully monitored. But otherwise, you know, that's, you know, after the wedding is done, who then checks up on the outcomes. And so we are going to have this important lecture from Dr. Elias Risk. He's the Chief of Pediatric Neurosurgery at the Dell Children's Hospital in Austin, Texas. Professor of Pediatric Neurosurgery there. Thank you very much, Dr. Risk. Looking forward to your lecture. Thank you.
Thank you, Naren, and thank you for bringing all our community here to talk about important pathology. And as you saw, there's lots of more work to be done, and hopefully the young folks will be inspired and take this forward and give us more information and ways to practice how to treat this complex disease. And I certainly learned a lot trying to, you know, canvas the literature as far as outcome measures and how we assess those. And we, you know, at least from my end, I think we still do a very poor job doing a comprehensive evaluation of the patient, not just from their symptoms, but also, you know, what are the best testing modalities? How do we screen for, you know, apnea, for speech difficulties, for cognitive dysfunction? There was a recent paper from Pittsburgh looking at cognitive changes before and after decompression surgery, and how headaches could be, you know, a significant factor with alteration of the child as they grow. And what does it mean for pediatrics or for the, you know, more of the adult population? How do we manage Chiaris in pregnancies? We didn't talk about that. How do we manage Chiaris that present with certain pathologies in addition to the Chiaris, growth hormone malformations, synostosis, etc. So it's really helpful to look at that as a whole. I have no financial disclosures, and you know, the focus of this talk is understanding the most valid and responsive instruments for clinical practice and research in Chiaris. And before diving in, I just wanted to mention that we all talk about Hans Chiari as the person who described Chiari malformation, but as a matter of fact, Shane Tubbs delved deep into this historical question, and it turns out that it's actually Theodore Langhans who described this pathology about a decade earlier, and he reached out to his descendant family, and they started a grand foundation and research on the topic of Chiari malformation. So my mentor, Dr. Oakes, used to say, if you want a new idea, go read an old book. So there's always somebody before you that has described some pathology or ways to treat certain diseases or diagnosis. I think Naren would love that small tidbit here. The challenge here is the outcomes and how various pathologies occur in Chiari malformations. And it's important to understand the literature and how you read it. And a lot of the analyses and outcome analyses is understanding the importance of the area under the curve or the receiver operating curve. And it's important statistics, especially when you're evaluating a binary outcome for patients, that they get better or not, are they sick or healthy. And those are performance metrics used to evaluate the quality of this classification. And it measures how well a model can distinguish between two classes, positive versus negative, like I said. And you can do that by plotting the true positive rates or the sensitivity of the study or the outcome. And again, this is plotted against the false positive rate, which would be the 1 minus specificity at various classification models. But the take-home message, if you really want to distill this, is if you have it as close to 1 as possible, it's a perfect model and we'll always get it right as much as possible. There's no such thing, but as much as possible. 0.5, it's a useless model. It's like flipping a coin. This really doesn't help you much. And if it's below that, it's something that you should not be focusing on. There's several outcome measures in the literature, and this is some of the most often cited outcome measures. Probably I put it up the top, and something that you have to remember and maybe start to implement into your practice is the Chicago Chiari Outcome Scale. And if you're on the Naren listserv, you probably got a recent email on the calculator that he created as far as how to assess those. It's fairly quick and easy to put in, but something that you should implement into your practice. This is an outcome score that not only focuses on pain, but also has non-pain symptoms, functionality, complications, and the higher the score, the better. It's validated in adult and pediatrics at 0.9 and 0.9 and 0.95 for the pediatric populations. It has a very high sensitivity and specificity, and that's exactly what you need from a test. And it's also the correlation between domains are pretty high and reliable across different centers and different places in the world. So it's not just focused to one institution. The patient-related outcomes are the short form 12th Health Survey questionnaire, the headache disability index, the visual, the VAS head pain score, and the neck disability index. And those have various less numbers as far as the area under the curve. The highest, especially in the adults, is the neck disability index. These are, quite robust questionnaires, and it behooves you to do those ahead of the evaluation. You don't want to sit with the patient for half an hour trying to fill those questionnaires. And there's electronic forms of this. So nowadays you can send it out ahead for the patient, fill it in for you, and keep track of those findings. So as you can see, the area under the curve is quite high, but not as high as the CCOS outcomes. As far as the pediatric patient related outcomes, you'll see that the quality of life measures, there's several other factors that we can include, including the PROMIS or proper score. And those numbers are slightly higher than the typical or slightly lower than the CCOS, but still something to use in your practice if you choose to. The radiographic and clinical correlations typically are not perfect, and clinical improvements can be visible by imaging, but sometimes you have a syrinx that stabilizes and that does not respond. And that's not always often after Chiari malformation, but does not mean that your procedure did not achieve the appropriate success. And emphasis should be on validated clinical outcomes in adult and pediatrics. So as far as recommendations in the adults, you can try the CCOS for global assessment for patient-related outcomes. the NDI, SF12, and EQ5D are good patient-related outcomes. For pediatrics, for patient-related outcomes, you can rely on the PROMISE and PROSPER and the CCOS for clinical correlation. And, as far as, typical VAS with a low area under the curve, or imaging alone, it's not something that you just should rely on and base your practice on. So that's pretty much my distilling of the literature, and happy to answer any questions.
Thank you very much, Dr. Risk, for that clear and important lecture on outcomes. Outcomes are that is the what you call the proof of the pudding. But sometimes, most of the times, we don't seem to be able to do it. I will come to that in a second, but may I please invite, first of all, Dr. Samar El-Baba, who's our faculty for this session with Dr. Patkar. Dr. El-Baba, do you have any questions and comments to Dr. Risk? May I get Dr. Patkar to come in first then? Thanks, please.
Yeah, I think this was a very nice lecture by Dr. Rizk. Ultimately, I think the most important outcome measure is a happy patient. He's not very interested in what you have done and how complex was the operation and how a brilliant surgeon you are. What is important is whether the patient is happy with your procedure or not. And at the end of the day, that is what matters. Everything else is will keep on churning, and probably like he showed the first slide, somebody has already done that before. Medicine advances by what is called as research, that is searching again already what exists. But in the end, if your patient is not happy, then it's not worth it.
Dr. Risk?
Yeah, I 100% agree. It's also patient selection and, making the realistic expectations with the patient, because sometimes patients come to you and they expect you to save them. And something we don't really talk about, and I'll be interested in the group's opinion here. My practice, when I talk about Chiari's, especially related to headaches, the headaches, I tell them they're not going to improve overnight, and we're going to do the surgery, and it takes a while, and you won't see the child's improvement. And I've seen it in our patients, but not really seen it described. It takes about 4 to 6 weeks to see the true start of the benefit of the surgery, because a lot of time patients come in back for their wound checks, or they call in and say, "Oh, the headaches are still there. Nothing has changed." Not sure what the observations are from the group as far as the start of improvement of specifically the fleeting headaches that Dr. Limdick referred to in the Chiari malformation cohort.
Dr. Jallo, do you want to come in, Dr. Jallo? When do you actually measure the outcomes?
Yes, I agree with you wholeheartedly. I don't discuss outcomes or begin to measure them for at least 3 months. I don't want to hear about, headaches, paresthesias, numbness, if there's a syrinx for at least 3 months. And the families are very worried because they assume that, oh, they have surgery on Monday, Tuesday, they should be 100% improved. And that's clearly not the case. And I think, my recommendation for others is it's the honest discussion with the families and the children, right? That it's not, the operation's going to happen and that they're not going to wake up 100% better.
Yeah, 100%. And taking the time will improve their satisfaction, like Dr. Patkar referred to. So sitting and really spending half an hour to an hour reviewing everything from the surgery, complications, but also expectations after the fact is really, really important.
Oh, yes, I have a question. I struggle with the syrinx and the bone-only decompression. I don't know if you do a bone-only. I don't, as I said in my lecture, I don't get the scan till about a year, and that's when I expect the syrinx to get smaller. I've had a few patients where the syrinx isn't smaller, but they're completely asymptomatic, and I struggle all the time what to do next with that, if one should do anything.
So I tell patients that the likelihood of the syrinx improving is about 80%, and the rest either stabilize or change in size. Stabilization is also a success because things are not improving. And, for the syrinxes, I don't see the syrinx. And I used to say, oh, yes, we'd have to absolutely do surgery if I just see a syrinx. That's a good indicator for surgery. But nowadays, I try to repeat imaging, probably like Dr. Brockmeyer has referred to, in small syrinxes to show progression and say, okay, you need surgery, to see if it actually reverses or changes, because some of them are not going to change or stabilize. And that's probably the Park-Reeves database. As far as doing bone only or not, I think, to me, at least based on what I've read in the literature about recurrence and redo surgery, I present that to the families and say, we might have to go back in, or we can do the whole thing one and done. And I quote a rate about 5 to 15% based on what you read. And the majority of pediatric parents decide to do the duroplasty versus bone only. On the adult side, they tend to do more of the bone only versus the duroplasty, because they just, are more comfortable taking that decision on their own and saying, I'm okay repeating the surgery if it needs to be done. So that's my practice and my observations. And I'm sure it's going to change the more I listen to more wise, experienced surgeons.
Dr. Risk, I've got a question for you. Why do you think that we don't do systematic outcome measurements? Is it time? Is it we don't have the nurses to do it? Is it we have problem keeping the records? Or I think if you don't, I did Chiari, but from the normal pressure hydrocephalus, we had the same problem. Certainly research centers might have an outcome, but others don't keep an outcome as soon as we do all the tests before. But as soon as the operation is finished, there's a bit of a drop off of the objective measurements. What's your thoughts? What's the reason for the impediment?
I think it's multifaceted. I trained with dinosaurs in neurosurgery, Dr. Oakes, Dr. Diaz, and many others. And I think they were passionate about taking care of pediatrics, but we didn't emphasize outcome measures from a surgical perspective. It's all, we took out the brain tumor, you can see it visibly. You fixed a deformity of the spine, you can see it visually, but we didn't have the exact tools to know how to measure and evaluate those patients. And it's hard to canvass the literature and say which outcome measure we should be using. But now, the take-home message is probably the easiest one to implement in your practice is just try a CCOS on those patients. And for the patient-related outcomes, you can pick NDI for the adult side and PROMIS for the pediatric side. And if you implement that in your practice, you can start to accrue that information. And I think us as a community, we need to start a consortium of Chiaris and look at specific questions that are easily targetable. When we all together are doing, hundreds of Chiaris all together, we can figure out what's the best outcome measures and how to tweak those outcome measures to make them perfect. So I think it's multifaceted. We've not been trained. Now it's being implemented more. It's a matter of knowing what to use, and also as a group, because if I do 5-10 Chiaris in my year, it's not going to be enough to collect all that data moving forward and make a meaningful impact in the literature. But if we, as 100 surgeons that do 5-10 Chiaris a year or even more, we can make more of an impact and prospectively follow these patients and talk more of patient-related outcomes and outcomes in Chiaris.
Thank you very much. I'm just trying to get the link for the feedback form. I just got it. Instead of that, I send the PubMed form. I'll just put that one before I make the last comment. Just a second. Chat. So yeah, I posted the form for the feedback, and it's a very simple feedback form. Once you complete it, give me a week or so, I will send you the certificates. and the database and the software and the online CCOS calculator. Before I go to give my thanks, Dr. Jallo, can I ask you to give your thoughts on the meeting today? Thank you very much, sir.
Naren, thank you. And first of all, I want to congratulate you on hosting a wonderful and just tremendous educational program for all attendees, as well as the faculty. I learned a lot today. I think the speakers were exceptional and were really just leaders in the field. The questions, the participants and their questions were highly, very intuitive, as well as, thought-provoking. So to you and the entire faculty, congratulations on an incredible symposium today.
Thank you very much. That's very kind of you, Dr. Jallo. In terms of I've got the recordings of all the lectures, but some of the lectures had pre-published data, so I need to just check with the speakers which lectures I can put online and which parts, or if particular parts of the lectures I need to edit out. So I will send them to you. I can't promise you when, but I'll send them to you as soon as I possibly can. So it really has been, anyone who has treated Chiari or who has treated Chiari, it's one of the most complex conditions, and every unit sometimes has a group think. I worked in 5 different pediatric neurosurgery departments, and every time I move to the other one, then there's a completely different group thing. I think it's important that we have meetings like this, whether I do it or others do it and controversies we can go for a week, but maybe one aspect on pre-op assessment, intra-op and follow-up, and I think maybe once every 3 months on the controversies. I think it's important that we talk to each other, we see that there are different practices, and I hope this symposium has given the distinguished faculty as well as the participants to run similar meetings in future. If I can, I will definitely do that. So it gives me a real privilege to have hosted this. It is a real pleasure and privilege to have hosted this meeting. So I really thank all the participants who came on this Sunday, and I'm very grateful to the faculty, expert faculty who have come to ask searching questions to the speakers, and the speakers, distinguished speakers, for finding time for this meeting. So I really wish you all a very good rest of the Sunday, and hopefully we meet again soon. But otherwise, I want you guys to run these things and have a great ongoing meetings in Craniocervical Junction. Thank you so much.
Thank you so much, Naren. Thank you, everybody.
Thank you.
Thank you, Elias, for the great talk. Thank you. Bye for now.